He's really
Share my screen.
yeah. Okay, so dear friends, we are continue our conference, and what I would like to do is to invite Simon Marr. Simon Marr is one of the great experts in first semester echocardiography and early fetal scan. He's really a superstar, and we will give him time to give two presentations, and after he will answer your questions because as you know, in Australia now it's close to night. So that's why we moved our conference this day a little bit early. And so please, Simon.
Thank you very much, Fred, for that introduction. And good morning, good afternoon, and good evening to you all from whichever part of the globe you are attending Fred's conference. You know, when I think back in time over years ago, when Fred was working at the Fetal Medicine Foundation and people were trying to understand the intracranial translucency, I remember opening this video clip on YouTube by a chap called Fred Ushakov. And I looked at the demonstration of the videos and the graphics, and they were just outstanding. They were amazing. And I felt that this was a video that gave somebody an understanding as to what the intracranial translucency was. I don't know if you ever saw this video, but if you have not seen it, look it up on YouTube. But he has graphics of the spaces fading in and fading out, the labeling of each of the individual lines and spaces. And so I heard about Fred Ushakov, or Fred, well before I met him. And then I remember that day when he said yes to my invitation to come out to Melbourne, and we shared a very nice weekend together, and have been at conferences since. So it's been an immense pleasure to be invited to Fred's first semester meetings, which are fantastic, very well attended, and are cutting edge, covering an aspect of medicine that is growing rapidly, but still, when I say growing rapidly in the hands of experts, but in a sense, there's a lot of room to move in terms of bringing everybody else into the belief to what Fred and I and others espouse as to the benefits of first semester screening, because we can achieve so much in the first trimester. And why wait to the mid trimester? Because your option managements and everything change and shrink as you move further on into the pregnancy. So my brief today is to talk about outflow tract anomalies, and I will be talking principally about tetralogy of Fallot, and I will be talking about the differentials on tetralogy of Fallot, which will include common arterial trunk and double outlet right ventricle. But for the most of this, it will relate to tetralogy of Fallot, because that's in the first semester where we have confidence of making that diagnosis. A common arterial trunk is a much more difficult diagnosis, and I will go through that with you as we work together screening the heart in the first semester. You will see that the title of my talk that I have up here, 11 to 14 weeks. Now, the reason 11 to 14 weeks is there is because historically, 11 to 14 weeks was the time that we measured the nuchal translucency. And therefore, because we were measuring the nuchal translucency over this window, we were also looking at anatomy. But may I add that looking at the fetus at 11 weeks is a terrible time to look at the cardiac anatomy, and looking at 14 weeks is in fact just a little bit too late, particularly for endovaginal scanning. The actual window of opportunity, which I would like when scanning a fetus, is really 12 to 13 weeks. And if I look and share with you what the model of care is at our unit at Monash IVF, or Monash Ultrasound for Women here in Melbourne, is as many of these pregnancies are IVF pregnancies, and they come in for a dating scan to exclude an ectopic pregnancy. For those that are not IVF, they come in for a scan because they want to time precisely when they should have blood drawn for free fetal DNA. So we draw blood at 10 weeks of gestation, and we do free fetal DNA analysis. It's a blood test. Now, it's an expensive blood test, although in Australia, a lot cheaper than many other countries worldwide. But you're looking at the order of $400 to have a free fetal DNA test. But before we draw blood, because that is still an expensive test, we need to ensure that the fetus is viable. We need to make sure that it's a singleton or a multiple pregnancy. And we need to see whether there's any signs of any complications that would make us think that we should not draw blood, that we should wait. So the point I'm making is we do a scan at 10 weeks, and the beauty about this scan at 10 weeks of gestation is that it allows us to very precisely date the pregnancy. So when the patients come back, we book them before they leave our rooms in for what we now call is the 12 to 13 week anatomy scan. We no longer talk about the 11 to 14 week scan because NIPT has replaced in our unit first trimester combined screening for Down syndrome. 90% of our patients opt for free fetal DNA in preference to first trimester combined. And I know that's different to what happens in Europe and in London. Contingent screening is the go. I accept that. But I predict in the next 5 years that globally NIPT will be a test, free fetal DNA will be a test provided for all. And the issue of costs will continue to come down and it'll match the price of a first trimester combined. And then it's a lay down Mézère. Everybody will have an NIPT. So everybody will have that opportunity of pregnancy dating. And that's one of the biggest advantages of NIPT is that you have to do a scan beforehand to make sure it is that you proceed with the test and therefore you time when to bring the patient back. Ideally for me, I like about 12 weeks and 5 or 6 days to 13 weeks to 2 and 3 days, 13 plus 2, 13 plus 3, that narrow window of 5 days. And we can do that because we've dated the pregnancy so accurately at a transvaginal crown rump length. And the reason I like that is because in the event of there being a problem, I can do a chorion biopsy and have a FISH before the patient is completed her 13th week. And that for me is a big advantage. For 14 weeks, I know that's too late in terms of offering chorion biopsy, because we really would bring those patients back and do an amniocentesis at 15 weeks in the event of there being a problem. But also 14 weeks, I don't like doing endovaginal scans at 14 weeks. I'm at that crux of changing over between abdominal versus vaginal. So what happens is patients arrive in our unit. They have take 2 glasses of water before they arrive for the scan, 20 minutes before they arrive to the practice. And then we do a transabdominal scan. We measure the crown rump length, BBD, head circumference, femur length, humerus length, and AC. And we do the biometry abdominally. And we then start and try and do as much of the anatomy transabdominally. And the important part of that is particularly with regard to the cardiac situs, is assessing the stomach on the left-hand side and the heart on the left-hand side. That's much easier to do that across all patients transabdominally. And where possible, we do that. And we take a split image showing the stomach and the heart, confirming that we've looked at situs in the first trimester. The patient then goes to the toilet, empties her bladder, and then we proceed with an anatomical survey that's no different than what we do, with a couple of minor changes to what we do at 20 weeks of gestation. The other advantage is once we've completed the assessment of the anatomy and the cardiac anatomy, which I'll come to in a second, we then bring the patient back to the morphology. We don't call it anymore the 18 to 20 week scan because we don't scan at 18 weeks anymore and we don't scan at 19. We bring patients back for the 20 to 21 week scan because, as Fred will have touched on this, is we expect to have excluded the majority of major fetal malformation at the 12 to 13 week scan. So in summary, we date, we bring patients after the dating scan for the NIPT at 10, we time the cardiac scan for 12 weeks and 4 days, to 13 weeks and 3 days, and then we complete the anatomy at 20 weeks of gestation. And that's the model of care. And I will touch on this in the next talk when I talk about transposition of the great arteries. I'm just going to give you a sneak preview of cardiac malformation at 6 to 10 weeks, because when you look across all organ systems, you appreciate in the NIPT scan that there are various malformations that you can see across the cardiac system in the bottom left-hand corner. You can see a 4-chamber view of heart and outflow tracts from 8 weeks onwards and an endovaginal high-frequency scan. And I'll show you examples of that with the new slow flow technologies. And I think the next shift will be looking for cardiac malformation as a certain small group of anomaly sequences at the pre-NIPT scan at 6 to 10 weeks of gestation. But that's not in my brief in this talk. We're going to be talking about tetralogy of Fallot. So in talking about tetralogy of fallow at 12 to 13 weeks, I want to start by talking about tetralogy of fallow in general and then move to the first trimester. And there's some aspects about tetralogy of fallow that are unique to the first trimester, which I will obviously highlight in my talk. The condition tetralogy of fallow consists of the VSD, the aortic override, pulmonary stenosis, and the right ventricular hypertrophy we do not see prenatally. That's the fourth of the tetralogy, which evolves postnatally. For us, what we're going to be looking for in the first trimester is the aortic override and the changes to the pulmonary artery, not necessarily the narrowing. I will talk about the narrowing, but it's actually the configuration of the pulmonary artery that's one of the key signs which enables us to pick it up in the first trimester of pregnancy. And of course, VSDs will always be challenging. I accept that. They are challenging in the first trimester, and we worry about false negative and false positive diagnosis. But if you know the limitations of ultrasound in the first trimester, don't stress about that. It's these two key factors, by looking in here, that we focus on picking up tetralogy of fallow in the first trimester of pregnancy. So you say to me, Simon, what's the evidence for that? Well, let's go through it. So I'm going to start off with the facts and figures behind tetralogy of fallow. Let's cover that. As we look at tetralogy, the four sections, when you look graphically, and this is taken from Cincinnati Kids, and I'm talking generally before I go to the first trimester, you will see here that the pulmonary artery is very narrowed here. And you rotate around the heart, the aorta is dilated, and you come around and the vertical axis is around, you see the pulmonary veins coming in here, and then the aorta is the most anterior vessel coming out of the heart, and you'll see that that is very significantly narrowed. And this is the main pulmonary artery here narrowed, and the branch pulmonary arteries, and secondarily, the aorta is dilated. When you step inside the heart and you look inside the tricuspid valves, you're now sitting inside the right ventricle, looking up towards the tricuspid valve. It's normal, but what you have here is a big gaping hole, as you see that you've got your ventricular septal defect. And as you look across that, that's part of the repairs, repairing your VSD. And as you look through to here, you see your pulmonary artery. And your pulmonary artery is obstructed. And as part of the treatment of tetralogy of fallow is to dissect the muscle around the right ventricular tract to relieve that obstruction. But that's why the pulmonary artery becomes reduced in size. An important note about the pulmonary artery in tetralogy of fallow, 80% of them will be pulmonary stenosis. 20% is there's actually no flow across the pulmonary valve. The definition of pulmonary atresia is when you reach a point where there's no flow across the pulmonary valve. So it may start initially during the developmental stages of tetralogy of fallow where there is flow, but as it progresses, the pulmonary artery may get narrower and narrower. And then once it reaches the point where there's no flow across it, then you're dealing with pulmonary atresia. And if you look at it, these carry a much worse prognosis, the tetralogy of fallow pulmonary atresia. And then there's the very rare form, absent pulmonary valve syndrome, which is the complete opposite. It's where you have a dysplastic pulmonary valve and you get a blowout with a huge pulmonary artery and dilated right and left main branches of the pulmonary artery, which is not typically seen in the first trimester, but I will show you an example of absent pulmonary in the first trimester. It's more commonly picked up in the second trimester of pregnancy, but you can pick it in the first by looking at the flow changes, the two-fro motion that is typical of absent pulmonary valve syndrome. So what I want to do today is to walk you through all these variations of mild, moderate, and severe degrees of pulmonary stenosis and tetralogy of fallow with pulmonary atresia, and I'll finish up with absent pulmonary valve syndrome, all cases in the first trimester of pregnancy. So if you look at the actual facts and figures of tetralogy of fallow, is one of the most common, it is the most common cause of cyanotic congenital heart disease, and it represents about 3 to 7% of major congenital heart defects. So if you look at the big ticket items, you're looking at transposition of the great arteries, coarctation of the aorta, hypoplastic left heart, and tetralogy of fallow. They are the four most common major heart abnormalities. You don't worry so much about hypoplastic heart because you know you'll more than likely pick that, but you worry about tetralogy of fallow, particularly if it's mild pulmonary stenosis. If you say to me, Simon, what is the evidence that exists to date that you can pick it up in the published literature? Well, there's a number of papers which I want to bring to your attention. When talking about the first trimester, we make reference to Kipros's Nicolaides unit. First author on the paper is Sinjlaki in these population studies, because these are fantastic in a sense that they give you a large population screened. I know it's a retrospective study, but it gives you a representative feel of 100,000 women screened in one unit. I know there are multiple different units contributing, but under the umbrella of the Fetal Medicine Foundation. And if you look at that, which was published very recently in 2019, there were 28 cases of tetralogy of Fallot. And if you look at that, 39% of these, nearly 40% of these were identified in the first trimester, 53% in the second trimester. One was missed and picked in the third trimester. And then there was a case where it was picked up postnatally. So close to the vast majority were identified prenatally. But that figure of 39%, I have to say I'm impressed by that detection rate from Kipros's unit, because these women were scanned transabdominally. 98% of these patients are scanned transabdominally, and it's only if they see a problem, then they proceed to endovaginal scan. Whereas if you adopted a policy, if in the first trimester you adopted a policy of doing the transabdominal, empty the bladder, then moving to transvaginal, I believe you can greatly improve that detection rate from 49% up to a much higher figure with routine endovaginal scan, because tetralogy of Fallot is a very detectable abnormality. So you say to me then, well, what's the advantage of making a diagnosis of Fallot's in the first trimester? Well, first, is that there's a significant association with aneuploidy, anywhere, depending on what you read in the published data, between 20 to 50% with aneuploidy. And in fact, that figure is much higher in the first trimester, because it is associated with aneuploidy, and many of these are identified, and patients may choose not to continue the pregnancy, or they're lost through natural attrition if there's severe chromosome abnormalities such as trisomy 18, 13, and triploidy. The other important one is 22q deletion, and this becomes important with the new technologies. When looking at for an absent thymus, you want to see the internal thoracic arteries, and if you look with slow flow technologies and radiant flow, you can see this in the first trimester, and that becomes very important in Fallot's in terms of you screening. If a patient's in two minds whether or not they proceed with testing, if you can see that the thymus is absent, or you can see that the thymus box is smaller when you reference the size of it by identifying the internal thoracic and slow flow, then that may swing a patient's decision to proceed with invasive testing if they're sitting on the wall. But for most in the setting, when you're identifying Fallot's and they know the other associated chromosome abnormality, they make a decision to proceed, and therefore looking at the thymus may be of secondary importance. The other thing to make note of is quite frequently you will see in Fallot's is a right aortic arch. And in fact, that may be the first thing that you pick up. So when you're looking at a four-chamber view of heart, you see your four chambers, you see the descending aorta posteriorly, and of a droma spine, you see the aorta sitting to the right of the spine instead of to the left. That may be the first clue for you in the first trimester that's positioned here, that you were looking at a right aortic arch. It may be the first clue that you're looking at a tetralogy of Fallot. So just be aware of that. These are very hard to pick in the first trimester, a persistent left superior vena cava, but just bear that in mind when you're looking at the three-vessel tracheal view to look to see is there evidence of a fourth vessel. It's very hard to see a dilated coronary sinus in the first trimester of pregnancy. It's quite difficult, even in optimal positions. But you know that once you've made a diagnosis of tetralogy of Fallot, your index of suspicion is so high that you will pick up persistent left SVC if it's present. So let me then next move to the next slide in terms of the published data that I'd like to share with you. And again, this is just published recently in 2020 from Paolo Volpe's unit of a retrospective study of 51 cases of tetralogy of Fallot, which they were detected. They may mention the first trimester. I know up to 16 weeks you're sort of extending into the early second trimester, but it's very relevant data. And the thing that for me is probably it's the first time which we've seen in print is what is the natural history when you make a diagnosis in the first trimester. Because for me, this was the biggest problem. A patient came to me, we made a diagnosis of tetralogy of Fallot. The patient then says to me, Simon, what is the outcome for my baby? And the problem is there's no data that tells me what proportion of babies who have a decent sized pulmonary artery and normal pulmonary valve will go on and progress to pulmonary atresia or a severer form of pulmonary stenosis later in pregnancy.
And therefore, over the years, I've been saying to patients, look, I'm sorry, I don't have a crystal ball and I can't look into the future as to how the pulmonary artery is going to perform. Because when I say perform, whether it's going to shrink, because ultimately with fallows, the prognosis and the outcome for babies with tetralogy of fallow ultimately depends on what is the size of the pulmonary artery, how well they do. This is the first paper that touches on it, and I think there will be more to follow over the years in that he recognized of those where the early detection, less than 16 weeks in tetralogy fallow, many of them the 12 to 13 week scan, is that 25% of these progressed by the time the patient reached the mid-trimester. And that, I think that's information that patients will want to know, that there's a natural history between a first trimester diagnosis and second trimester morphology. The other thing to note is that there's a significant association with other abnormalities. And for of those 51, 23 had associated malformation. And those 23, which is nearly half, chose not to continue with the pregnancy. And the other important point about this study, because it was a large number of fellows, was 2/3 of these presented with indirect markers. And that's why I'm talking about any cardiac abnormality in the first trimester, you have to lay importance to the indirect markers. So before we even talk about examining the heart, what are the markers that make us raise the flag and say, this doesn't look right? And 2/3 of fellows had those flags saying there's something not right here before we even get to examining the heart. The other third had no risk factors. And of course, they will always be the more challenging group. The other paper which I like is because I think I need to mention the importance of the Y sign. And this for me is probably the most powerful marker for fallows. When I look at the second trimester of pregnancy, it is also a valuable marker, the Y sign, the second trimester of pregnancy, but from the first trimester, the Y sign and axis deviation. So you've got the indirect marker of axis deviation and the Y sign and the three vessel and tracheal view, for me, is one of the most powerful markers for tetralogy of fallow. And I'll tell you what the Y sign is in a second. So if we looked at in this study, which was published in 2017, 17 cases of which there was a mixture of tetralogy of fallow and double outlet right ventricle with a subaortic VSD, which in a sense is just a further degree of dextroposition to the right, but otherwise very similar in pathology. And if we're looking at these, that the Y sign was present with a sensitivity and specificity of 94% and 99% respectively. Now, this was a very interesting study, which basically said the Y sign almost brings you to the diagnosis of a tetralogy of fallow. And in fact, when they looked at axis deviation did nothing but add false positives. So in fact, if you look at the Y sign on its own, and push aside the other markers in a sense, or cardiac axis deviation, which is the most powerful indirect marker for cardiac malformation, that the Y sign superseded it. In fact, you didn't need to look for X. If you looked at it that way, of course, we would never look at it that way, but if you looked at tetralogy of fallow and you said, Simon, what's the one section that you want in terms of making a diagnosis? I would say to you, it's the three vessel tracheal view, because on three vessel tracheal view, I expect to see the V sign of a normal three vessel tracheal view. Whereas here's your trachea and here's your SVC. Whereas what happens in tetralogy of fallow is the insertion of the duct into the aorta is abnormal. You end up with the Y sign. So the arterial duct enters in a more proximal and inferior position under the aorta. It does not come down to this distance here, which it should extend down to. It inserts at this point here. And therefore, the point where it enters is not at the level of the isthmus, it's actually under the arch. And therefore, in our three vessel tracheal view, we get our Y sign. And that's very important. And I think we need to go through examples of that as we travel through the sonography with you of the Y sign in tetralogy of fallow. But let me add, when I talk about the power of the Y sign in tetralogy of fallow, I will also clarify it by saying that this is not pathognomonic of tetralogy of fallow. The other differential diagnoses which you may see it are pulmonary stenosis, Epstein's, tricuspid atresia with VSD. So just bear in mind, it's not pathognomonic, but for sure, it should raise your index of suspicion. So this is just showing you the three vessel tracheal view, and you look at the point of where the arterial duct enters into the transverse aortic arch is very abnormal. And here's the duct, and here's your transverse aortic arch. This is your transverse aortic arch. This is your trachea, and here's your duct coming in here. And similarly here, your duct coming in here, transverse aortic arch. And if you look for all of these images, just let me get rid of all my drawings. How do I know that that's the duct? Because each time the vessel that's closest to the trachea will always be the transverse aortic arch. So that's how you define, in a sense, of where your duct is. You start off by looking at the point of where your trachea is, because the vessels that closest to the trachea in 99.9% of the scans that you do is the transverse aortic arch. So even without looking at the four chamber, and I haven't actually shown you the four chamber in any of these images. If you showed me these images, the first thing I do when I look at any image on the three vessel tracheal view is I go straight to looking at the trachea, and then I know that that's the transverse aortic arch, and then I start working from there. And that becomes a very important basic landmark in cardiac imaging. So that's a very powerful sign in the first trimester pregnancy and screening for Tralogy Fellow. I want to walk through the cardiac sketches because these are important before we start doing first trimester imaging, is to do the sketches. So if you ask me, Simon, what are the findings that you will see in Tetralogy of Fallow, I'll say, well, first of all, let me go to the ISUOG guidelines: the four chamber, the five chamber, the three vessel tracheal view, and then the next section up is looking at the internal thoracic subclavians. And so if we look at the four chamber, what you will see in 25% is left axis deviation. Left axis deviation 70%, right aortic arch and 25%. And then you may see an increased nuchal translucency in 50%. So that's still a useful marker, an important marker for first trimester diagnosis. Then if you look on the five chamber view, what you're looking for is aortic override with dextroposition of the aorta. The aorta is slightly dilated. Now, that may not necessarily be appreciated in the first trimester. It's a very strong marker. If you ask me, so Simon, what do you think is the strongest marker of Tetralogy of Fallow? The second trimester, I'll say dilatation of the aorta. And so that may not be that striking in the first trimester, but you may see the turbulent flow, particularly on 2D with endovaginal scan with harmonics. You will see that turbulent flow across, or the high velocity flow across the aortic valve, and I'll show you examples of that. And then I've already mentioned the Y sign. So let me, rather than just go talking about text, I prefer to do diagrams because sketches impress on you or give you an understanding much quicker than any text or description. A normal four-chamber view of heart is by far the most common finding that you will see in Tetralogy of Fallow. Left cardiac axis deviation may be the first indirect marker which you see, and of the axis deviation, it's left axis deviation. Let me stop for a second. There were two key papers. More recently, it was Rabi Chowis noting that in the order of about 2/3 of cardiac malformation, you will present with axis deviation, either left axis deviation or right axis deviation. Of those, 2/3 of all cardiac malformation I'm talking about, and of those, 80% of them were left cardiac axis and 20% of them were right axis deviation. So the more likely is what you're going to see in Tetralogy of Fallow is left axis deviation. The next you may see is the 25% who present with a right aortic arch. So normally the aorta should be to the left of the spine in all these cases. But if you find the aorta is on the right of the spine, that for you may be the first clue. And the other finding which you may see is that there's a perimembranous VSD. Now in the first trimester, the apex has to be up at an endovaginal scan with the spine posterior. These are very hard to identify at transabdominal scan. Unless it's a malaligned VSD, strong malalignment with dextroposition, you may appreciate it. On the five chamber, what you appreciate in Tetralogy of Fallow is that the aorta is shifted dextroposition to the right. So this is the right here, and this is the left. So normally the aorta should come down and it should be aligned perfectly with the anterior wall of the aorta, but there's a breach. And not only is there a breach giving rise to the VSD, but the aorta now sits astride both the right and the left ventricles, and therefore the aorta receives blood flow from both ventricles. In a sense, both pumps are pumping into the aorta, and hence that's why the aorta dilates. And secondarily, the pulmonary artery decreases in size. So in a sense, there are two reasons why the pulmonary artery decreases in size. One, because there's less coming out of the pump, the right ventricle, because basically formation of a blood vessel arising from the major arteries arising from the heart require flow to make them grow. It's part of vasculogenesis that you have flow. So the reduction in flow leads to pulmonary arterial stenosis. And the second reason is because of obstruction to outflow. The other thing that's remarkable about Tetralogy of Fallot is you can see in my first drawing that there's that nice swan neck appearance to the way the aorta leaves the heart. Well, that's lost in Fallots. They end up coming out straight. So the aorta rises in a straight fashion coming out. And you may note that in a 5-chamber view, that loss of the sigma curve, the nice normal looking left ventricular outflow tract. And the next thing you may see is this turbulent flow across the aortic valve. And you may see that in either 2D, particularly with stick technology on 2D, you may appreciate that high velocity flow. The reason being is if you set your PRF for a first trimester scan anywhere between 25 to 35 centimeters, or 20 to 35 centimeters, depending, you're going 11 to 14 weeks in the UK, is where you set your PRF. And when you do that in a setting with looking at it with the color, you will straight away see that there's turbulent flow at those lower PRF settings. Once you increase your PRF, you may get rid of some of that aliasing, but you will still see turbulent flow in some. Okay. And then the last, oh, sorry, 2 more seconds to go. Next to the 3-vessel view. And this is the 80% I was talking about. And this is where you want to be as a fetus with Tetralogy of Fallot. You want to be having a good size pulmonary artery, because the treatment of these babies is very successful. You know, the outcome in the treatment of Tetralogy of Fallot is very favorable. Most patients who are cancelled with pediatric cardiologist Tetralogy of Fallot, the good sized pulmonary artery, do or continue the pregnancy, and the long-term outcomes that we have to date are very good. So in that's the varying degrees. You're showing a slightly narrowed. And then this is the pulmonary atresia. Essentially, when you look in a 3-vessel view, you can't see a pulmonary artery. So normally you should see the pulmonary artery coming out with the branch pulmonary artery and continuing as the ductus arteriosus. But I've drawn a dotted line to show you, in fact, there's no pulmonary artery. And that's quite troubling, because you know, it's a much worse prognostic group. And then you always ask yourself the question, well, if there's no pulmonary artery, how are the lungs growing? Well, they have to receive a supply. So it's either through retrograde flow through the duct, and I'll show you that in the next section, or either they receive the blood supply directly off the aorta, bronchioles, or subclavians through multiple arterial pulmonary collaterals. And then there's this group of the 1% absent pulmonary valve syndrome. This is almost it's an oddity really in the spectrum of Fallots. And I think it should almost be taken out of it because it is so unusual. Because you may have this condition with an intact septum, no VSD. So you can have absent pulmonary valve syndrome, not part of Fallots, and absent pulmonary valve syndrome. Once there's a VSD with override, it ends up being included, but it exists without Fallots. The actual primary pathology in this is very different in the sense that there's a dysplastic pulmonary valve. So the terminology for this condition is actually not good. It should be called dysplastic pulmonary valve syndrome, because the valves are actually there. They're just dysplastic, and they essentially don't close. They don't serve as a mechanism of stopping blood for various parts of the cardiac cycle. So you have a seesaw motion back and forth across the pulmonary artery, like there's no valve there at all. And that's how we pick it up. You have red, blue, in equal volume of flow across where the pulmonary valve should be. So it's quite a characteristic finding. And because it's so gross, the amount of regurgitation equals the volume of forward flow, the pulmonary arteries just blow out. And some of them look like aneurysmal dilatation of the atria. When you see them in the 3rd trimester of pregnancy, it's very striking. But in the first, it's mostly an abnormality that is not picked because the pulmonary dilatation is minimal or non-existent. Then we're up to the next view, the 3-vessel tracheal view, which is your V sign. So you may see your V sign here. I've already drawn the Y, so that's not included in this image. You may see the V sign, or you may see, in fact, that there's no ductus arteriosus to be seen. Now, that could be that it's either pulmonary atresia or the actual ductus sitting underneath the aorta. That does happen, but that's more likely to happen with a right aortic arch. So the arterial duct, when you've got that 25% of fallows and you can't find the arterial duct, it will almost certainly be sitting inferiorly. And that's where you really have to play around with your color settings to ascertain whether you're getting reversal of flow along the arterial duct. And then this is one just showing reversal of flow. So this means that flow is going back to the pulmonary valve, and then from there, blood is being fed to the lungs. So it doesn't, the pulmonary valves here, and there's, let's say it's atretic, and you have pulmonary atresia now, well, the blood reaches the lungs by going back through the pulmonary arteries in a reverse direction. So it comes out of the left and right ventricle through the VSD, travels up through the transverse aortic arch, and then down through the duct into the right and left. If you don't see this reversal of flow, you then immediately are suspicious. Well, actually, the supply to the lungs is not coming via the duct. The supply to the lungs is actually coming directly off the aorta. And this is where you need to look, and I'll show you examples of this in the first semester, pulmonary arterial collaterals. So you need to look there. And the other rarer forms will come off the subclavian, and the others will also come off the bronchioles, and they are very challenging to pick prenatally. So that's the graphics going through the ISUOG 5 sections, and the last section is the neck. When you're looking at the internal thoracic artery, I should have included it, but I didn't. Internal thoracic artery and vein. You have your sternum here, and then you have your left brachiocephalic vein here, and in here you have your thymus gland. So you're looking to see with slow flow, and I'll show you the examples in images in a second, but you're looking for slow flow showing these tiny vessels, and they will outline the box, the thymus gland. If that's absent, then the whole aorta you will find is shifted anteriorly. So that's the sixth section, which is a really more fits into a fetal echo setting rather than a basic ISUOG 5 section screening. So now let's get on to some ultrasound pictures and start with the cardiac markers of tetralogy of Fallot. So the first is an increased nuchal translucency. So if you go in and do a scan and you find that your nuchal, as in this case, the nuchal translucency is up around 7 or 8 millimeters, before you even go to looking at the heart, you know there's about a 70% chance there's an underlying cardiac malformation. Now that could either be as part of aneuploidy or it could be isolated. At the end of the day, once you get big nuchals, the odds are more likely to be a cardiac abnormality than not, and therefore it becomes important to do a fetal echo. Next is looking at a tricuspid valve regurgitation. Now I'm showing this to you via a Doppler. So here's your E wave and your A wave, and then here's your big dip of your tricuspid valve regurgitation. E wave, A wave, and then it's a pansystolic tricuspid valve regurgitant jet. So you place your Doppler gauge across the tricuspid valve, 2 to 3 milligauge. You magnify your image. You place your gauge either side of the tricuspid valve. You have an angle that you must keep within 30 degrees of the interventricular septum. You take 3 samples and you're aiming to get more, if it's more than 60 centimeters a second. Now, these were all criteria that were used for Down syndrome screening. I'm talking about cardiac malformation. And in a sense, we don't do this anymore because we have NIPT. So in a sense, pulse Dopplers become less and less valuable for me screening for cardiac malformation. What is becoming increasingly valuable for me is actually looking at color, because we routinely look with color in the first semester of pregnancy, and the ISUOG guidelines will be updated shortly to include that. So here's my descending aorta, which defines my left atrium, my left ventricle, my right ventricle, my right atrium. So remember, the descending aorta is your anchoring point. And here you can see your tricuspid regurgitant jet. And that for me is a far more valuable way, because I don't want to be picking up the mild tricuspid regurgitation. I want to pick up the cardiac malformation tricuspid regurgitation. Well, I shouldn't say I don't want to, I want both. But by setting your PRF of around 20 centimeters a second, making sure that you get ventricular fill, you will see your regurgitant jet. And then there's the ductus venosus waveform. Again, that was really historically over Down syndrome screening. We adopted both tricuspid and ductus venosus to reduce the false positive rate with nuchal translucency, our first semester combined screening. Again, we do not do ductus venosus anymore in routine screening since we've adopted widespread screening by NIPT. So in a sense, we're left with these two. color Doppler, regurgitation jet, and nuchal translucency in cardiac screening. The next is axis deviation. So if you go into work tomorrow morning, first of all, I want you to focus on these 3 points here, because these 3 points are the points of the spine. This here is the vertebral body, and this here is the transverse processes, and this here is the fetal rib. So if I draw a line straight through the chest, and that's the vertebral body, you draw the line. You draw a line straight through the vertebral body from 6 o'clock to 12 o'clock. You will see that this axis is at 90 degrees. Normally, it should be at 45 degrees. So this is a typical example of a left cardiac axis deviation. So if you go into work tomorrow morning in a fetus at 13 weeks and 2 days of gestation, and you scan, and the first thing you see is the heart is lying on its side with its apex at 3 o'clock or it's 9 o'clock, depending on whether it's breech or cephalic, you must first suspect a cardiac malformation. And right on the top of that list are the conotruncal abnormalities, and the right on the top of the conotruncal is tetralogy of Fallot. So the next you want to know is you want to go through your 5-section analysis of the heart. If you're just screening, you will probably just be looking at a 4-chamber and 3-vessel tracheal view. So on the 3-vessel tracheal view, if you haven't spotted the axis deviation, the 3-vessel tracheal view, you have a greater than 90% chance of seeing a Y sign. So in terms of, just let me spend 1 minute on that, on screening in the first trimester of pregnancy, the suggested in the next guideline will include a 4-chamber and 3-vessel tracheal view on color. I know the current guideline dissuades you from using color, saying don't use color. The next guideline will do the absolute opposite, do use color. And do use color, and as a minimum standard will be to look at the 4-chamber view and the 3-vessel tracheal view with color, setting your PRF at around 25 centimeters, 35 centimeters a second, around 13 weeks of gestation. I would suggest, I know the guideline will include 11 to 14 weeks, given that contingent screening will be with us for a good number of years before we move to the advanced screening test with free fetal DNA. So in terms of the sonography, I want to run through the sonography and start by just showing you those 2 sections. So first, this is another case. If you go into work tomorrow morning, I ask you to focus on the vertebral body, which is here, and here's the transverse process, and then just draw your line vertically through the chest, and then you can see that this heart is lying on its side. And in fact, you don't actually measure the axis. So routinely, we don't measure cardiac axis, we eyeball it. But that's the important thing in routine practice is you do eyeball axis, you make a note, and that's why all the sonographers in our unit, they do a split image showing the stomach on the left-hand side and then the heart on the right in a single frame, confirming that they've actually assessed the situs and axis. And that's a very important thing to do in routine screening. As you sweep up from this heart, you recognize that the axis deviate, but when you come up to your 3-vessel tracheal view, you see this very abnormal configuration of the aorta, and this is referred to as the question mark sign, and was described in the 2nd trimester of pregnancy. So if you look at that, it looks like a question mark, and that was described in the White Journal by Martinez back in 2010. My God, it only seems the other day, 10 years have gone quickly. But the question mark sign is also a very powerful sign in the 1st trimester of pregnancy. So in a single sweep in this fetus, I've already got clues on 2D. So if I look here is my superior vena cava, I can't see my arterial duct, because my arterial duct should be here, the transverse aortic arch should be here. And that is clearly abnormal as well. So that's the 3rd sign. So I'll run the clip again so you can see that slowly. So we start off on a 4-chamber. There's left axis deviation. We sweep from the 4-chamber to the outflow. There, in fact, is your aortic override as you sweep across very subtly. And then you sweep up to the 3-vessel. And as you do so, you then see this big aorta. Now, remember I said to you about aorta being enlarged. That's a very powerful sign. The 2nd trimester of pregnancy, it may be of value in the first, but I don't think it holds the same power as a marker for a tetralogy of Fallot. Then you look on the 3-vessel tracheal view, and you look in the 3-vessel tracheal view, there's my trachea, there's my SVC, so I know that that's the transverse aortic arch. You don't have to show me the 4-chamber. You don't have to tell me whether it's cephalic or breech. You don't have to tell me whether it's spine up or spine down, although I can see that. But the beauty about this landmark is once I know where my trachea is, I know where everything else is. And this is the point where the arterial duct is inserting. The arterial duct should not insert there. The arterial duct should be coming down and inserting here, and it should be equal in size to the transverse aortic arch. So this is my duct, and this is my aorta. And this point here is the isthmus of the aorta. Remember, when you are looking at an aortic arch, you see the vessels that are given off, which is your brachiocephalic, your left common carotid, and then you have your left subclavian. Then the aorta continues its merry journey down the body, and at the point where the ductus arteriosus enters here, that segment of the aorta is referred to as the isthmus. And that's the segment that you are seeing right here. Let me just get rid of this drawing. This segment here refers to this segment here, there to there, because the branch left subclavian has been given off by this point here. So what happens in tetralogy of Fallot is the duct is actually inserted more proximally. So on a 3-vessel tracheal view, the duct comes in here, and that's why you get the Y sign, because it inserts into a more proximal position. And as you look at it here, the normal duct ends here, whereas in tetralogy of Fallot, the duct enters here. Okay. And it's next after that, you would move to looking at the left ventricular outflow tract. Now, the left ventricular outflow tract is hard in the first trimester when compared to the pulmonary artery. In a sense, it's the reverse in the second trimester. If you look at the ISUA guidelines for second trimester scanning, the left ventricular outflow tract can't be obtained in 2% of the scans, whereas the right is only 1 on a large population study of 16,000, which the guideline was based on. So the LVOT is much, in a sense, is harder to get, whereas in the first trimester, we really struggle with it. So let's go to the next image, is the power settings. So in terms of power in the first trimester of pregnancy, I think we are spoilt with choice now, because first of all, we have standard color, which this is. After that, we have power, which this is. And then after that, we have radiant flows next, and then we have slow flow. So over the years, the technologies have changed. And I think as technologies have changed, it made it easier for us in the first trimester, because when you look at this image in the first trimester, it's quite hard to make out the individual vessels here. It's quite hard to make out the individual chambers. You could argue that I haven't optimized my settings. I said that's true. I would take that criticism and I would need to continue to work on my settings. But if I go straight to radiant flow, I'm now beginning to get a definition that I have 2 separate ventricular cavities of equal size, and now I'm getting better definition, which showing me that I have a right aortic arch, because in the center here I can see my little trachea. But when I move on to the newer technologies of slow flow, I'm now seeing a 4-chamber view of heart, which I'm getting a beautiful outline of my left ventricle, and I'm getting a beautiful outline of my right ventricle and right atrial cavity. I'm also seeing my pulmonary veins coming in, and that's at a single button press. This slow flow technology, in a sense, the controls that you have on it, are the principal control is power. So it's less easy to drive. The key things you have in driving it are one of 3 factors to drive. One is your background, which I always turn off. So background is off. The next option, in terms of radiant, I always select max. It gives me best definition. And then my color map, I mostly will select floor. If you want monochrome, you can choose different maps. There are a total of 8 maps. So background off, max radiant, and a map of 4. And that's exactly what this is. So if you look at the window, there's no, you're seeing straight through. There's no pain to it. And then I can see my right aortic arch. And not only can I see my right aortic arch, but I can see my internal thoracic vessels, and I can see my subclavians. I can see my right aortic arch, and I can ascertain then in terms of the branch subclavians that come off. So as the years have gone by, the resolution of ultrasound has come a long way. And I think this new technology for us is now shifting cardiac diagnosis back to the time of the pre-NIPT scan, but it's allowing us at the time of the anatomy scan at 13 weeks to look at fine vessels and quickly access. So it's really, for me, the real power of it relates more to anatomy, defining vascular anatomy. When I'm looking at flow disturbance, I would look at standard colored flow. I will take off radiant and look at standard. So I'm looking for disturbance, for aliasing, turbulence. I would not choose by default radiant. I would do standard color. And this is just showing you the power of these technologies in the same patient with the right aortic arch. It's not only showing the subclavian artery and vein, or subclavian artery is giving you both the artery and vein, but it's also giving you the internal artery, the internal mammary artery and vein, and it's giving you the brachiocephalic. And if you want to choose a different map, this is the left ventricular outflow tract. Again, just mapping anatomy. So if you see here, it shows the left ventricle and the continuity of the flow along and the sigma-shaped curve of a normal left ventricular outflow tract. So that the straightness that you would see in a tetralogy of Fallot is not there, and that gives you reassurance in the setting of a right aortic arch. So in terms of tetralogy of Fallot, we can go through varying degrees of stenosis to atresia. We will cover examples with intracardiac malformation, extracardiac malformation, aneuploidy, and then we'll finish up with absent pulmonary valve syndrome. So I'll start off with a sagittal section of a fetus at 13 weeks of gestation, and you will see as you look at that a nice thin nuchal translucency. That's a good start. You will also see that the intracranial translucency here is normal. And that's also reassuring because it's a very strong marker for chromosome abnormality because the fourth ventricle is enlarged. And then as I sweep to an axial section, I see this left cardiac axis deviation. So the nuchal translucency is thin, that's a tick for that. The intracranial translucency is normal, that's a tick for that in terms of aneuploidy. But what's concerning me is that when I rotate from looking at the nuchal translucency to the four-chamber view of heart, I see there's axis deviation. So the next thing that I want to do in this fetus is I want to look at the 5-chamber and the 3-vessel tracheal view. If you're somebody who's earlier in your training, you may pick it up by simply saying, I want to look at my 3-vessel, and if it's abnormal, I'm referring it on to Fred for the scan or to a pediatric cardiologist for a scan. But if you want to take it and do the 5 sections yourself, well, then do it. Rotate onto a 5-chamber. And as soon as you rotate onto a 5-chamber, you now see the aorta sitting astride just here, the interventricular septum. And then if you sweep up to your 3-vessel tracheal view on 2D, you appreciate that you have a transverse aortic arch. Here's your trachea, and there's no signs of your duct in this section. So now you have axis deviation and you have aortic override. So the next thing that you want to do is to move from that, is to move to a 3-vessel view. So this is the same patient. And now you will see that the earlier images were obtained at the transabdominal scan. Okay, that's when we first suspected was the axis deviation. So then she emptied her bladder, and then she came back in, and I went for a 5 to 9 megahertz transducer. So my option 6 to 9. So 5 to 9, 5 to 9 and 6 to 12. So 5 to 9 and 6 to 12 are the 2 transducers. So, and you basically judge that this is the workhorse, the 5 to 9. And if you're getting nice images of the 5 to 9, then you move to the 6 to 12, and that gives you superb images of fetal anatomy in the first trimester. So as you sweep in this fetus from a 4-chamber to the 3-vessel, you now sight the pulmonary artery. Now that's very reassuring to see that, but you see that the pulmonary artery is clearly much smaller when compared to the aorta. So here's your aorta, which is dilated, and here's your pulmonary artery. But for me, it's reassuring because when I looked at it abdominally, I couldn't see the pulmonary artery on 2D. Again, that's because of resolution. And then the next one I moved to, the fetus, you'll see, is that turned into a very difficult position for me. So when I'm faced with that, I don't give up because unlike the second trimester, you can transmit ultrasound beam through the fetal spine and ribs and image. And this is a very important point. You see, it was a lousy position. So the next is I reduce my sector width. Next, I reduce my depth. And then I invert the image. And when I invert the image, you will now recognize the landmarks, just like you were doing it as a transabdominal scan with the apex up. And you start off with your marking your descending aorta, left atrium, left ventricle, and right atrium. And then you rotate onto 5-chamber. You now see here is your aortic override. So here's your ventricular septum. And you can see before we turn on color, let's go back. Before we turn on color, we can see here the walls of the aorta sitting astride. I'll just freeze it on the frame there. So this here is the wall of the aorta just here, the wall of the aorta here, and here's your interventricular septum. So you have your right ventricle feeding here into the aorta and your left ventricle giving rise to dilatation. But you will see here that the dilatation is really not that, I mean, to me, it looks normal. And it sort of makes sense that it looks normal because the pulmonary arteries are a reasonable size. So when I'm scanning this feature, I'm beginning to ask myself the question, is this a malaligned VSD? Is this just a perimembranous VSD, or is this a tetralogy of Fallot? And then when I turn on the color tells me almost instantly. So when I turn on the color, I want to know, where is the arterial duct and where does it enter? And as I do so, I see this is my aorta here. First of all, I don't like seeing red because that should be inflow is red and outflow is blue. So I have to invert my colors here because I have inverted my image when looking at the heart. And you see, imaging through the spine and ribs with an inverted image gives me all the information that I need to know. Why? Because it's the first trimester. In a sense, that's the power of the first trimester because there's less ossification of the bones, and you can do that. You can invert the image. That's seldom successful, where this is routine in practice for us to invert the image in the setting of a spine up fetus. And then when we turn on the color, we then grab the point of, here's your transverse aortic arch. How do I know? Because that's the trachea. Label it properly. That's the trachea just there. And then here's the abnormal insertion of the ductus arteriosus under the aortic arch. So I've got all the features that tell me that this fetus. Next, I'll move on to stick. And let me show you how to do that. So the first is I go to the very beginning, and then there are three things you choose, which is your region of interest. And so this is quite a magnified image. Normally I would start with low magnification and then take a single sweep from head down to abdomen. But when I know that there's a problem, I hone into the area of interest. Then I choose the acquisition time, and the acquisition time is 7 to 15 seconds. And then I will choose my quality. So if I look here, the stomach, if I select my region of interest, I select my acquisition time, and then my depth. So my depth of acquisition. So I want to know how far do I go? Well, for me, I'll probably want to go the full depth of the heart. Now, the first trimester, 35 degrees is enough. The second trimester, because the heart's bigger, you would probably go for about 40 to 55 or 40 to 50. And that just tells you how deep it goes. So it's your region of interest. How long are you going to acquire for? Because if you acquire a very quick sweep, it's very tempting to do that because the fetus moves so often the first trimester. You don't want it moving the middle of your acquisition. The problem with that is the quality drops off. So if you want to be ambitious and go for 15 seconds and hope the fetus doesn't move, you will get your best volume. And then the depth is how much do you want to acquire? So that's only three controls you need in a sense. So what I've done is I've selected here my region of interest, and then it's acquiring, and it's acquiring through the full depth up to the 3-vessel tracheal view, and it goes a little bit higher just to catch the thymus. So we go back to that again and rewind it. Starts in the stomach, comes up to the descending aorta IVC, entering into the right atrium, 4-chamber view of heart. The left looks smaller than the right. You see the aorta sitting astride, and then you see the abnormal insertion of the duct. You see the transverse arch, and that's a sweep of about 30 degrees. So I've gone for 15 seconds. Just let me tell you that because you can't read that on screen because I always go for 15 seconds. I know it means I have to acquire more volumes, but so be it. I want to get the best quality. And now I've got a stick volume that shows the abnormal insertion of the duct. You see how much easier it is to see the aorta and SVC and the trachea. And then I can see the very abnormal insertion of the ductus arteriosus into the aorta. And now I take a 3D tomographic ultrasound slice. And in doing so, it shows me the 4-chamber view up to the 3-vessel tracheal view. And you will note, in a sense, which is one concerning aspect about this fetus, is that you see that there is some degree of ventricular discordance as you look in that acquisition. So the left ventricle looks slightly smaller when compared to the right. And the same fetus I also did was a 2D acquisition. So this is a color stick, and this is a 2D stick. You look at the center image here, you can see how much more clearly this displays the aorta sitting astride the interventricular septum. So this is a dextral position of the aorta, and this is just showing you here the slight discordance between the right and left ventricle. There was also a minor degree of tricuspid valve regurgitation. So there's a few other things going on. In the same fetus, I wanted to know, did it have a 22q deletion? So I moved straight to putting on my slow flow technology. And the landmarks that I'm looking for here is my brachiocephalic vein going across, and these are my internal thoracics coming up here, and this here is my thymus. So I can see very clearly, and that's the power of slow flow on an inverted image with spine up, with slow flow technology. I can see that the thymus gland is present and is normal in size at 13 weeks of gestation. So let's move on to just some more examples. This is a features at 13 weeks of gestation, a thin nuchal translucency. When we look at the landmarks of the ductus venosus waveform, we see the ductus venosus waveform is normal. Here's your A wave just here, and that's a good depth. So it doesn't go anywhere near reaching the baseline. But when I looked at the four-chamber view of heart, so these markers were all normal, but when I looked at the four-chamber view of heart, and this is with a 9 linear transducer, which gives a very high frequency, I could see that there was cardiac axis deviation. And when I swept up to looking at my aorta, you may see that there's only a single vessel on the 3-vessel tracheal. I know it's the aorta because that's the trachea. You may not like that image because you think it's too hazy. I actually like it because I know I've got really maximum frequency, but you may want to move down either for the C2 to 9, or you may want to move to the C4 to 8 megahertz. And we'll do that in a second. So this is the first image. So now if we split the image, this is at 13 weeks and 5 days. We have the apex here at 9 o'clock, and we have a left aortic arch here sitting to the left of the spine. But when I rotate on this fetus to a 5-chamber, you can see that the aorta is sitting astride the ventricular septum. And then I go up to my 3-vessel view with color, and you can see here you've got a dilated aorta, and there's I can't see my pulmonary artery in view. So that is, again, all the features that you would see at, at 18 weeks gestation, making a diagnosis of tetralogy of Fallot. So I come across in the same fetus, just showing you again with the 9 linear, which I like in the first trimester of pregnancy for abdominal scanning, and I rotate on that. And as I rotate on that, I can see the aorta sitting astride the interventricular septum. And actually you can see the aortic arch dilated here on a 5-chamber view. And just go back to that point, you can see just the aorta here, just sitting astride the interventricular septum, just that point. Okay, so we next move on to an endovaginal scan. So this is the stomach, and then we sweep. This is the descending aorta sitting to the left, where we already knew that. Because what I want to know now is where the pulmonary arteries. You can see abdominally, there was no sign of a pulmonary artery in sight. So the only way of knowing whether that's real or not is by going to an endovaginal scan. And as I go to the endovaginal scan, I actually see that this is the branch pulmonary artery here. So this one is a little bit more worrying than the previous case because these are tiny little branch pulmonary arteries coming in here in this fetus with tetralogy of Fallot. So I'm now moving along the spectrum of a more severe abnormality. And you would do it again. I'll show it to you. Sweep, descending aorta, left ventricle, and I'm just going to pause when the pulmonary arteries come in, and there they are there. So you have tiny pulmonary arteries. And in a sense, when the pulmonary arteries are tiny, the aorta is going to be more dilated. And that's one way of prognosticating in Fallows by looking at the aorta to pulmonary artery ratio throughout pregnancy and Z scoring. And there's no data for that in the first trimester. But in a sense, if you see a very dilated aorta, the first thing I always think of is pulmonary atresia. Because I think if it's that dilated, there's not going to be any pulmonary artery. But the only way I have knowing of that in the first trimester is by magnifying the image, turning on color Doppler, and then going to the slow flow technology. And I'll show you the power of slow flow in this setting. And then you can see your very dilated aorta here, your SVC. And then this is just going with slow motion, again, sweeping up from your 4-chamber up to the 3-vessel tracheal view. And as you do so, you see these tiny pulmonary arteries just coming in there, right pulmonary artery, left pulmonary artery. So this is a moderate degree of pulmonary stenosis. And then as you come around to the arch, you want to know, in a sense, in terms of color flow through the arches, there's still forward flow. And you can see there still is forward flow in the pulmonary arteries, but that doesn't mean that there's going to be forward flow later in gestation. Excuse me. The next I still look at these markers. I'll always look for ductus venosus just to get an idea of the pressure of the circulation. And it's good to see that there's forward flow. in the A wave, and I look also at the fourth ventricle. Fourth ventricle for me is a very powerful marker for chromosome abnormality. So when I look here, I look at the aqueduct of Sylvius here. You can see the box of fluid, and then I come down posterior to that or inferior to that, and I see the fluid of the fourth ventricle. And I'm looking here is this black fluid full space. And that should, if that's increased, that makes me think that this is a Fallows related to chromosome abnormality. I'm sort of going way over my time here, so I might just speed up a little bit. I'm just here, a thin nuchal translucency, a normal intracranial translucency, a normal ductus venosus waveform, another example of a Fallows. And I haven't mentioned much about the trouser leg appearance, but when you look at your left ventricular outflow tract, you will see the aorta sitting astride on collar Doppler. So if you as you do this in this clip, it shows that. So we'll freeze it on. You will see the ventricular, both ventricles filling the aorta and giving that appearance of a trouser leg, sweeping up in color. Here we have the transverse aorta, but there is no sign of the pulmonary arteries. We need to come around to the bottom left-hand view, and that will show you the pulmonary arteries. So this shows you the trouser leg appearance of the aorta here. So that's the aorta coming out, being filled by both the right and left side. And on this case, when you look at it, you can see there's actually a good sized pulmonary artery. Anytime I see a good sized pulmonary artery, I always question, is my diagnosis correct of Fallows? I know there's left cardiac axis deviation. Yes, there is aortic override, dexter position, but when I see these good sized pulmonary arteries, I always question it. And that's important. I'll come to the very end of my talk about false negative and false positive diagnosis. While I show you nice examples of these pathologies, you need to always caution yourself in the first trimester. But this is the same patient actually a week earlier, and this just shows you why I prefer 13 weeks. So these are the images of 14 weeks, which are much harder. This is the same patient a week earlier, 13 weeks, 2 days, and this is just showing you the sweep from the forechamber up to the 3-vessel tracheal, and you can see that Y sign. It was so much easier to see at 12 weeks. And it's just, as I say, I don't like doing hearts at 14 weeks endovaginally. And there's the Y sign. And coming around here, it's even a better image of it here. They see that now you can appreciate that pulmonary artery is small here. And then here's your dilated aorta. Much easier to appreciate 1 week earlier. And this is here just showing a full sweep coming up from the forechamber, and then sweeping up to the trouser leg appearance over the ventricular septum, and then the very abnormal insertion of the duct into the transverse aortic arch and the dilated bulb. All right, so that's all examples of pulmonary artery of varying degrees of stenosis. This is where there's no pulmonary artery in view. So it's 13 weeks of gestation, you sweep from a forechamber and you see your question mark. Now you recognize that question mark appearance. But at this point with color, I actually can't see reversal of flow because that's what I should be seeing here. Is any flow? Next, I move to a color stick evaluation. I can see left and right ventricle. Here's the descending aorta there. That's the left ventricle. This is the right ventricle. There's tricuspid valve regurgitation. Then I can see my question mark of tetralogy of Fallot. But on all of these images, I still haven't seen, with my color stick, I still have not seen any signs of my main pulmonary artery. So I go to my 5-chamber to confirm that it is a Fallows, and I see a nice example of the aortic override. And as I do so, I can see the aorta turning the corner, but it's just at this point here that I'd like to be able to see whether there's any pulmonary artery. And I sweep up to the 3-vessel tracheal view, and there's no PA. Here's my trouser leg appearance here of the fill going up. There's the aorta, the trouser filling here, and filling here, and filling here. And then this is just showing with using a stick render, where you can see that big dilated aorta. And that, that point I make, if you're seeing the aorta that dilated, you're going to almost certainly be looking at pulmonary atresia. And then the next thing is to find the MAPKAs. So that finding the MAPKAs is in the first trimester. Again, remember the point I made about radiant flow and anatomy, and increasingly we will find slow flow will be valuable in the first trimester. Well, the first thing I think is when I see these vessels coming off the aorta, I always say, well, the first is, am I sure that that's in fact not reversal of flow along the ductus arteriosus? And the only way of distinguishing the MAPKA from a reversal of flow is actually watch this vessel. It branches, And once you see it branching, you know that that is not reversible flow along the arterial duct. These are maculae coming off the aorta. So the lungs are receiving their supply from these multiple tiny arterial branches. And that's very significant in terms of counseling the patient, because from a surgical repair point of view postnatally, it's the maculae that are a real challenge, how to manage these. And then this is just showing you the using the silhouette with a color render, showing that big dilated aorta, the see-through, that you see your ventricular septum and each ventricle filling into that big dilated aorta, and that giveaway that you're not going to be finding a PA. The PA is going to be absent. So that's a tetralogy of Fallot with a pulmonary atresia. So we've gone through the spectrum of changes that you may see. I now want to take you outside of the heart for a second, because once you see a tetralogy of Fallot, you need to look for coexistent abnormalities. So this is a fetus with a crania, and you can see here with an anterior abdominal wall defect. The next one, you look at a four-chamber view of heart. You sweep, then you can see the trouser leg appears, you can see the dilated aorta, but you can still see forward flow in the PA. So this is a tetralogy of Fallot with forward flow, but beginning to see signs of reversal. I know it's completely academic because the fetus has a cranial omphalocele incompatible with survival, but these are the moments that you should seize the opportunity to learn, because the greatest chance you will have is in the first trimester, because there's a much higher incidence of cardiac malformation in the first trimester when compared to the second. So you will see far more cardiac abnormalities. This is taking a stick volume and showing you the power of stick. Now, this is a stick from almost 10 years ago. So if you look at the aorta in this same fetus with the crania, you can see the aortic valve and the power of stick 2D. You can see that hyperdynamic flow across the aortic valve. You can see the aorta sitting astride the interventricular septum. And then once you take a color stick, you can see this tiny pulmonary artery. But you can see in the middle image signs in just one portion of the artery that there is signs of early reversal. And you can then take a stick rendered image. And again, it doesn't look as pretty as the current stick volumes. But anyway, it still gives the same message of that big dilated stick volume over 9 years ago, that big turbulent dilated aorta with predominantly forward flow through the arterial duct with a slightly more proximal insertion of the Y sign. And B flows, which sort of really disappeared from our systems. I liked B flow when it was there, but this just shows you're turning around on the Z axis. So the heart is down here. Cardiologists prefer this view, the interventricular septum. And then this is your aorta sitting astride. So this is your big dilated aorta, and showing that proximal insertion of the duct under the undersurface of the aorta with a B flow technology with stick volume. 40 assessment with B flow. So the acquisition is not in color, the acquisition is not in 2, the acquisition is in B flow. All right. And then, so that's an example of extracardiac malformation. Also bear in mind, once you have a thin nuclear translucency, normal fourth ventricle, normal nasal bone, you do sweep to do a four chamber, you see cardiac axis deviation. And then the next thing you see is you look at the heart, you see that there's dropout in the region of the AV valve. Be very careful about that. It's really ideally when looking at AV canal defects, you need to try and make sure the apex is up, but this is a pretty obvious AV canal defect. So this is a far more complicated picture. This is not just tetralogy of Fallot, it's a tetralogy of Fallot with an AVSD. So this is looking at the 5-chamber in the same fetus, and you can see the aorta sitting astride the interventricular septum. And then you look on color Doppler, you then move with color to see what the flow pattern is. Can you see the pulmonary artery? So you've got an AV canal defect, and you can just see the tiny flicker of red telling you that you are looking here with reversal flow along the arterial duct. So this is a pulmonary atresia with tetralogy of Fallot and an AV canal defect. Anytime you see that, you always suspect, if asking the question, well, is it a tetralogy of Fallot or is it a double outlet right ventricle? And then you've got to start asking yourself, is it in fact an isomerism? You need to start looking to see if there's evidence of anomalous pulmonary venous return for right atrial isomerism, or an interrupted IVC for a left atrial isomerism. So from there, you say, well, I've labeled this as pulmonary atresia because I can see reversal of flow along the ductus arteriosus. The amazing thing about slow flow is may completely convince you of being something else. But while you may see reversal of flow, it actually tells you is that you have pulmonary arteries. Now that's very important to see that, because at the end of the day, this becomes the key thing in prognosticating is the size and presence of the pulmonary arteries, and also differentiation of the different cardiac abnormalities, telling me that this is not a common arterial trunk. So the power of slow flow, I think, will make a big difference to us in these challenging cases when the pulmonary arteries are so tiny in pulmonary atresia and other forms. And then remember, I've mentioned all along about aneuploidy. So if you go into work tomorrow morning and you scan this patient, can you tell me what's running through your mind as you look at this fetus? So this is at 13 weeks of gestation. And the first thing that strikes you is you say, crikey, that head looks very big. But in fact, the head is not very big in this fetus. The head is actually appropriately sized. Its trunk is actually tiny. And you may also think that the ventricles look enlarged. And of course, the ventricle you want to know about is the fourth, because you've spotted that this fetus has got a very thin placenta. You've also spotted that the trunk is very narrow. And you've also spotted that the fourth ventricle is dilated. So these are all the typical features of digynic triploidy. So this is a fetus with digynic triploidy with a tiny narrow body and the big head with a prominent fourth ventricle. And then you move to looking at the heart, and here's your question mark sign of your aorta. So you can see that big dilated aorta sitting astride your interventricular septum, no pulmonary artery in view. And this patient at 13 weeks of gestation declined genetic testing. Didn't want to have any invasive procedure and wanted to continue the pregnancy. So this is the same patient back later in pregnancy, and now you can see the heart, which is actually quite tiny for 16 weeks. It measures 1 centimeter, so it's like a 13-week heart. And you can see when you thought there was pulmonary atresia, you can see there is actually a tiny degree of flow through the pulmonary. So it still is, I shouldn't have said pulmonary atresia, it's a pulmonary stenosis, but you can see the aorta sitting astride the ventricular septum. You can see that the heart is grossly enlarged. So this is a chromosomally abnormal heart, the triploidy heart with dilatation of the right atrium, override of the aorta, a small pulmonary artery. So a conotruncal abnormality in the setting of triploidy. So just bear in mind. And then there's this case of absent pulmonary valve syndrome, again from many years ago. So this is a split image demonstrating color fill of the right and left cardiac ventricles. But when you sweep to look at the right ventricular outflow tract, you see something very abnormal. You see that bidirectional flow across the pulmonary valve. As you see, it goes red, blue, red, blue, red, blue. But it's not actually, if you look at it, you will see on 2D, you can see momentarily, it might be in the next image actually. In this split image here, you can actually see the high velocity flow, and you can appreciate that there's no arterial duct. You go up to the 3-vessel tracheal view and there's only 2 vessels. You come back and you see the pulmonary artery, and there's bidirectional equal volume of flow of red and blue flow because the pulmonary valve is dysplastic. So this is a very rare abnormality, number one. Remarkably, there's a published series in 2017 of 40 cases of absent pulmonary valve syndrome, which is a staggering number. So a much higher frequency of this in the first trimester of pregnancy, again, because of these, half of them were related to trisomy 13 and 18. They never get to the second trimester by virtue of their strong association with chromosome abnormality. And then they have a strong association with extracardiac, and then with tetralogy of course, with tetralogy of Fallot. And I did mention it may exist without tetralogy of Fallot, and there's a significant proportion of those. So to show you the next page, I think it shows you, it does. So this shows you more of the same patient. So the heart measures just under a centimeter, endovaginal scan, high frequency. And you can see the cardiac axis deviation well before it was described, actually. And then you can see the magnified image of the pulmonary artery. You can see that turbulent flow, equal volume of flow back and forth from the right ventricle to the branch pulmonary artery, but they haven't dilated yet. And then as you sweep up to the 3-vessel tracheal view, you will then see the dilated aorta because it's sitting astride. This is an absent pulmonary valve syndrome as part of tetralogy of Fallot. And as you sweep up with your stick volume up to the 3-vessel tracheal view, you'll see that there's no connecting duct. I think it continues all the way up, does it? No, maybe the next clip. So I'll show you, I think it's the next clip shows it. Yeah. So this shows you up at the level of the 3 vessels. There's the trachea, there's your transverse aortic arch, and as you sweep down from that, you will see there's no connecting duct. So the duct is absent, and that's pretty typical of absent pulmonary valve syndrome. Most, the duct is absent. And then this just shows you a full sweep going from the 4-chamber up to the 3-vessel tracheal view. And as you sweep here from the pulmonary arteries up to the arterial duct, there's no duct. So that is a rare one, but bear in mind, if you do see it in the first trimester of pregnancy, bear in mind that strong association with aneuploidy. So I think next is moving on to the differential diagnosis. And as we talk about differential diagnosis, it's important to bear in mind is double outlet right ventricle. So this is a fetus with a thin nuchal translucency, normal 4th ventricle. And as we sweep to going on to a 4th chamber, we see this cardiac axis deviation. Compare the quality of that image to the quality of an endovaginal sweep. So this is showing the same fetus at endovaginal scan. But when you look at the override, this aorta is coming predominantly out of the right ventricle. So this is the left ventricle, and the aorta is coming predominantly out of the right. So once it's more than 50% across the ventricular septum, we then call that a double outlet right ventricle with a subaortic VSD. So you look at the apex of the heart, you draw the interventricular septum. So in tetralogy of Fallot is when it's rising out of the ventricle like so. But if you find that actually it's going further across, coming predominantly out of the right ventricle, it then becomes called a double outlet right ventricle. And this is the left ventricle. If the vessels are transposed, so they're switched, well, then that's the double outlet right ventricle with a subpulmonary VSD. But that's a talk for another day. It really fits into the differential diagnosis of transposition of the great arteries. Let me not confuse you. So this is an example of the aorta was more than 50% across, so it's an important differential. In this fetus is a thin nuchal translucency, which is very reassuring. The 4th ventricle is not in view. The cardiac axis looks normal, but when you come down to looking at the same fetus on a color stick volume, you can see that the trunk comes out of the right ventricle. So this is the pulmonary artery, the aorta, and it comes out of the right ventricle. 40% of common arterial trunks come out of the right ventricle, and the other 60 sit perfectly astride the ventricular septum. So this is an example of a common arterial trunk. And another one from over 9 years ago, a thin nuchal translucency, endovaginal scan, sweeping up, axis deviation with the right aortic arch. You can see the aorta is sitting to the right, and that big vessel coming out of the center of the heart. And as you look for the pulmonary artery, you can't find it. There's nothing coming out of the right ventricle. So you know you're not looking at a double outlet right ventricle or a tetralogy of Fallot, because the pulmonary arteries are actually coming off the trunk. And if you look closely here, you can see the pulmonary arteries are coming laterally off the large trunk. And this is a stick volume analysis of the same fetus with a common arterial trunk. And chromosome biopsy confirmed this was a fetus with 22q deletion. I have to finish by just saying a few words about VSDs. You've got to be careful about VSDs. You do apply the same rules. 1, you look for edge enhancement. 2, dropout. So this is your dropout here. You're looking for a little bright echo for edge enhancement. And next you're looking for color. And there's your echo just here. Every time I freeze, the echo disappears. I have to time it better. So let me get rid of that. So you're looking at, there's the edge enhancement. Anytime you see that, you have to rotate in a 5-chamber and ask yourself, is that a VSD with malalignment or not? And that can be extremely challenging in the first trimester of pregnancy. But the question I ask myself is the aorta dilated? In this case, it is. And is the pulmonary artery in view? No, it isn't. So if I see a VSD like that, then I go asking myself, are there other markers there that support? And then I use stick. I can see the dropout, edge enhancement, and then I can see my aorta sitting astride the ventricular septum. As soon as I see my VSD, my next question is, are there any other VSDs? So this is a heart that measures 8 millimeters. It's on the smaller side for 13 weeks. And I see my dropout. anytime I see a dropout, I ask, if I see one VST, I always ask the question, is there another? And you will see actually here, there's also an additional VST, which is a mid-muscular VST in this fetus. And again, you go through the motions of ascertaining whether there is the aorta sitting astride. So on making this diagnosis in the first trimester of pregnancy, what's the management and for these patients going forward? Well, the first thing is I'm an obstetrician. I'm not a cardiologist. So the first thing I involve a pediatric cardiologist, and that's in a sense where you learn so much from. Um, is we have a fantastic, two fantastic pediatric cardiologists in our unit, and I've learned so much from them over the years. And as a team approach to how we manage this patient going forward, because for us, we're the imaging side, the obstetric side, the genetic side of things. But once that's all sorted out, it's the pediatric cardiologist who takes it going forward, and that's probably the most challenging aspect of managing any patient going forward in the future, because they are in the position where they have to manage the patient, the partner, the family going forward, and counseling a patient given all the uncertainties. In a sense, we are presenting them with additional uncertainties by making early cardiac diagnosis, because for some of these cardiac malformations, we have to accept that number one, your diagnosis may be revised later in the pregnancy. When I say revised, it may be refined. Maybe that you thought it was a Tracheophalo with pulmonary atresia, but in fact you see the pulmonary arteries, the mid-trimester by way of example. But fundamentally, you need to be certain that the core finding of a major abnormality is going to require cardiac surgery, which for many patients is the trigger as to what decision they are going to make in regard to invasive genetic testing or whether regarding the continuing the pregnancy or not. But ultimately, involving a pediatric cardiologist, increasing that workload for pediatric cardiologists, we are increasing uncertainty by making earlier diagnosis, because there are more possible outcomes when we see patients back at 18 to 20 weeks. But I think, as by the end of this course, Fred's course, you will be absolutely convinced that you can make certain diagnoses. Don't get me wrong. I'm not saying that, in terms of you just need to be sure that you bring in a cardiologist, that you have that certainty that you are doing the right thing. And I'd say the team approach, because you're also bringing in genetics. So you need to exclude that there's a chromosome abnormality. And for these cardiacs, we offer chorion biopsy. If there's uncertainty about the call, then, we may consider bringing the patient back earlier and doing later and doing an amniocentesis. We do not offer NIPT. There's no point in doing an advanced screening test. We do offer chromosome microarray, particularly in the setting of the co-truncal abnormalities. And on current data, there's good evidence that we'll pick up the other additional deletions and duplications, which we historically would have not picked up in the banded karyotype. I don't want to go down talking too much about that. So we'll bring the patients back after counseling them about the Tracheophalo, excluding chromosome abnormality. And we sit down with the geneticist, and that'll be an hour's consultation going through how to manage these patients going forward, or close to an hour. And exclude other structural malformation is a very important part of all of this. And then we bring the patients back in the mid-trimester. And from the mid-trimester, it's not really the brief of today's talk, but the key thing is working out how does the pulmonary artery progress for the pregnancy. And there are various, predictors of outcome by various studies, which again is not the brief of today's talk, of Z-scoring various vessels and comparing the ratios of the pulmonary artery to the aorta, and maybe another day we'll discuss that. But in terms of how patients are cancelled, they are cancelled with the, a lot of this is on 30-year, 40-year survival data, is that we cancel these very favorably with 30-year survivals ranging from 68 to 90% of the current literature. And the Melbourne Cardiac Surgery Service is, it's got a long-standing reputation behind it, and their figures are up at the 90% in terms of the outcomes for these children. So they are most patients in our unit will choose to continue the pregnancy in the setting of a good sized pulmonary artery when the diagnosis is made. But be mindful in cancelling the patients. And of course, people cancel them in different ways. And in terms of morbidity, be aware that morbidity is common. And, some patients aren't prepared to take on that morbidity because, there is residual right ventricular outflow tract obstruction requiring reoperation. There is residual regurgitation, there are ventricular arrhythmias, and there's often a need for re-interventions later in life. So in a sense, that becomes important to counsel patients realistically about these common morbidities. While we talk about overall success rates for 30-year survival, you must counsel in a sense survival with morbidity, but that falls into the realm of a pediatric cardiologist. And that's where, in a sense, I'm blessed by having two pediatric cardiologists who I say I've learned so much from over the years. I won't touch on specifically on the surgery, but I'll finish up with the take-home messages. One, remember, when looking at a four-chamber view of heart and outflow tracts in your first trimester scan with color, look for cardiac axis deviation. 2, look for the Y sign. 3, look for vessel discordance. 4, understand the left ventricular outflow tract may be challenging. And next, look for the main pulmonary artery, because that becomes so important in prognosticating. And finally, in the setting of making a diagnosis of a co-truncal abnormality, be aware of that strong association with chromosome abnormalities, 22q deletion, and so on. And always be mindful the possibility of false negative and false positive diagnosis, and the importance of having been surrounded by a team of quality cardiologists, geneticists, and have a good team in ensuring that you counsel these patients appropriately going forward. Fred, I didn't ask you, but I hope you don't mind me just giving a plug for our masterclass series, the first of which was last night, but we will be back on track again with the next in our series in November and December. We won't be having one during the Congress, but in November and December. And you can join in on these later in the piece and still pick up the one that we had last night with Dario and Giulini. And I might finish the first talk there, Fred, and see if there's any questions before I get my next talk ready.
Actually, yeah, fantastic, absolutely amazing lecture, and it's clear that this is lecture about fetal echocardiography, early fetal echocardiography. So, Simon, amazing. Congratulations for this fantastic talk. And I have two questions that maybe you can answer. So one question is if, oops, one sec, question's gone. But one question that I have, if perimembranous VSD in 4-chamber view is the same as VSD in 5-chamber view in tetralogy of Fallot.
Oh, it's a very good question. Well, yeah. In the setting of seeing a perimembranous VSD, it's on the 5-chamber view when I'm entertaining the differential diagnosis with tetralogy of Fallot. It's not on a 4-chamber view. You may suspect a perimembranous VSD. The difficulty in terms of the 4-chamber view is when you're sweeping up from a 4-chamber to a 5-chamber, you're moving from the inlet to the outlet. And that can be spatially very hard to appreciate for somebody who's junior in their training. And even for an experienced individual, if you really want to work out whether it's a perimembranous outlet VSD, you need to come around to a 5-chamber, because that's the one you want to know. There's actually a slide, if I still have is my screen still being shared? Do you still have my screen?
No, it's not shared.
No, okay. So when looking at that 5-chamber view and you've got a VSD, one of the key questions which you need to ask in that setting is there, can you see any evidence of malalignment? But for me, what becomes most important is there a color wash? Look, let me just go back and show, because it is a very important point, and share my screen. You can ask if there's any other question when I'm getting it ready, Fred.
Other question about its technique, I think it's more for Peter after, because it's talking about slow flow. So.
Okay, share screen.
Another question, can we assess left outflow tract 5-chamber view in prone inverted images in the second trimester? So,
yes.
People ask.
I see about the inverted image. Are you able to do it in the second trimester? Yes, absolutely. I invert my images regularly. So if the fetus is not in an ideal position, I mean, in the large BMI, it doesn't work. But in many other patients where the fetus is in a good position, I can invert the image. And for me, it just, it's remarkable when you do it. You only believe on it if you do it on a regular basis and get used to what it tells you, because um, it in a sense normalizes position and layout of things for you, and it drives you to continue. Whereas sometimes you look and say, "Oh, damn, it's spine up. I can't see a bloody thing." But actually, if you realize you are forced to do it, and that's through my life, I've been forced to do it because I've got another patient in the waiting room, and I have to demonstrate, I have to take a record of my DICOM of an image of a 4-chamber and a 3-vessel tracheal and an LVOT, and if I can get that image by inversion, I do it, and it works. But it's yeah, it is hard. It is hard going.
But I think it's very difficult
But
because
possible. Yeah.
I know for me it's difficult to see because there are different groups of people doing transvaginal scans. So people who started to do IVF, they're looking this way, and people who started to do anomalies, they're looking this way. And there's different units looking from different way. And for me, so I started to look like this, and it's very difficult to change the because when you're doing manipulation, it's quite complicated. So
I,
it's
yeah,
very good
I agree.
technical.
Yep. So just coming back to that question about the override, one of the there's a very important point to make about all of this. If I can draw good. So if I actually draw over this line here in terms of a perimembranous VSD on a 5-chamber view of heart, where you see frequently, and this relates to more the mid-trimester, you will frequently see dropout at exactly this point. And this is a very common, ignore that. This is a very common reason why a patient is sent to me in the mid-trimester, because they see dropout. And because when the valves close, there's actually quite frequently a dropout at this point. It is impossible to have a VSD at that point. So number one, if you're going to see dropout, it has to be below the level of the valves. That's a very important point. Next, when you see that dropout at this level here, the next question you have to ask yourself is that true or is it false? You magnify the image up and you ask yourself, is there continuity or loss of continuity? If you think there's loss of continuity, the next way for me then, and I can't draw with this pen in color unless I go full screen, the only way of me knowing is whether there's actually a wash across, is by then turning on color and then seeing a wash of blue red. And then the way I do that next step is on stick. If you come to the next webinar, which will be on Tetralogy Fellow, I will demonstrate this to you. But you can see a wash of color across on standard color, and then next move to stick technology, and then you will demonstrate that it is a true, it's not an artifact, because it is possible. It is easy to make a false positive call of a perimembranous VSG on a 5-chamber view. I hope that answers your question.
Yep. I hope to.
Fred, am I doing on time? Because I actually didn't start my watch at all.
Yeah, actually we are running out of time, but I think you're talking about so important things that we will give you full time to talk, and
Okay.
I will make my talk shorter. Thank you.
Okay. So I'm going to make this talk short. The talk is shorter. Oops, that's the wrong talk. Let me get the right talk up.
Yeah, it's also interesting talk.
Yeah, I've taken a slide from it. That's why that's open. Okay, so let me go full screen. So the next one is transposition of the great arteries. Let's go full screen. Have you got me on full screen? We're good? Okay. So transposition of the great arteries is a far more challenging diagnosis in the first trimester of pregnancy. So these are the key images which you are looking for. You're looking for the inflow here on red. Why is my pen not working?
You are out somehow.
Yes, I'm not sure what's happened. My PowerPoint just bombed out. It's okay. I'll get it back now.
No, it's so annoying this with the internet.
Yeah, because
Yesterday I had to- yeah,
it slows the whole system down, Fred. And as
Yeah.
you say, you have technical problems. You were saying
yeah.
it's actually gone and taken those slides out. Oh, that's annoying. Okay, look, I'll just go straight to
Yeah.
full screen. It should be good now.
Yeah.
Actually, Fred, just bear with me for 1 second, can you?
Yeah,
Because I
yeah.
think
Don't.
it's worth just for 1 minute to see if I can bring that up, those extra slides, which is this one here. Okay.
So I just would like to tell, because yesterday really we have significant technical difficulties, and I decided that I will re-record this yesterday's presentation. So it will take a little bit longer to put this presentation on the Assess. So, but it will be re-recording of the presentation, because I think you need to see good presentation, not interrupted all the time. Thank you, Simon.
Thanks, Fred. So, transposition of the great arteries is a much more challenging diagnosis when compared to trilogy of Fallot, but there are some useful clues that are particular to the first trimester, which I will go through. If you look at the transposition of the great arteries, it remains one of those abnormalities that still the detection rate is low globally. I know in centers of excellence in Paris and other centers of, high quality, both transabdominal and transvaginal scanning, the detection rate of TGA is around 90%. But in the rest of the world, it's still challenging. So I think that I can't think of one abnormality that has so many clues described for it. There's like 13 or 14 different markers. And anytime you've got an abnormality that has 13 markers, it tells you a story. It's difficult. So if I just stop for a second and say, well, what is transposition of the great arteries? Firstly, the right atrium is connected normally via the tricuspid valve. So this is your right atrium connected through a normal tricuspid valve to a right ventricle. The left atrium is connected normally via a mitral valve to the left ventricle. So there's no atrioventricular discordance. It's all absolutely fine. The problem relates is that the great arteries are switched. So the pulmonary artery comes out of the left ventricle. So coming out of the left ventricle here is a pulmonary artery, and then that goes out into the lungs. And then the aorta arises from the right ventricle. So this is the right ventricle here, which gives off the aorta, which goes to neck vessels. So the problem is you end up with two circulations that are completely dependent of each other. And when you come to repairing these, and this is why I like this diagram, because it actually shows when you do the arterial switch, this is the normal fetus here, and this is the fetus with TGA here. When you come to doing the operation after birth, is that you switch these vessels. But when you switch the vessels, you have to also take the coronary arteries. So you have to take the coronary artery off here. There is a patch when you do the arterial switch. That becomes very important when I start talking about ultrasound prediction of outcomes in TGA. So transposition of the great arteries is one of the most common cyanotic congenital heart defects. And remember, I said to you the four was coarctation of the aorta, transposition of the great arteries, tetralogy of Fallot, and hypoplastic left heart, the big four ticket items, the most common abnormalities. So TGA is the most difficult of that four. Right up there, around 5% of congenital heart defects. And when you look at it, you can divide into two types: simple, 55%, and complex, which is the 45%. The complex basically means there's something else. A VSD, which would be the lesser, then a more significant is the right outflow tract obstruction. That tends to develop late in pregnancy. In the third trimester, you're more likely to see that. And that's why it's important you track these patients after making a diagnosis. And then the other problem is coarctation of the aorta, much less common. So if you think of it, VSD or a problem with either of the great arteries, the pulmonary stenosis and for the narrowing, both of them narrowing for the aorta coarc. For most of these, they have a low association with chromosome abnormalities. It's very unlike TGA, but we still offer genetic testing. And I'll show you examples of chromosome abnormality with TGA in a second, because again, the first trimester, it's more likely that you will see an associated abnormality, more likely that you will see aneuploidy, because it's chromosome abnormality is more common in the first trimester than second. The detection rates on this latest review in 2020 on an overview of world stats was that 50% detection rate. But this Lisa Hornberger's unit published not too long ago showed some optimism in that our detection rate, when you think the period 2003 to 10 compared to 2014-15, which is far more recent, is in the order of 70%. But again, that's in Lisa's unit, and I say Paris, Lisa, world centers of expertise, detection rates are high. But I think this is probably a figure that's more representative, certainly what's happening around the world. And Australia, we're probably halfway between those 2 points. It is an abnormality which is important because we know if we make the diagnosis antenatally that there's good evidence of these 5 references here, which is in tiny font 8, that there's improved outcomes if you make an antenatal diagnosis. So that's now solid information in the published data, and therefore the pressure is on us to make the diagnosis. If the mother will ask, or may ask down the track, well, why didn't you make the diagnosis before birth? Because my baby would have done so much better. And she's right, in a sense, they would have done so much better. In terms of knowing about it, it allows a multidisciplinary team involvement, it allows timed delivery, administration of prostaglandin, and timed balloon septostomy. Because as I mentioned to you, these circulations are completely independent, they're not connected, which is terribly abnormal. And you need to, in a sense, maintain that connection. So you need to keep the ductus arteriosus open. And therefore you can administer prostaglandin, and then you put in a balloon and pull it back across the foramen ovale, ripping the foramen ovale or interatrial septum, so to allow mixing of blood. Now, one of the biggest challenges that we are faced with prenatally is the restrictive foramen ovale, and I think that's it happens by virtue of high oxygenated blood returning to the left side by virtue of the transposed vessels that causes this abnormality in the foramen ovale. It becomes restrictive. And for us prenatally, it's not so much a first trimester thing, it's more a third trimester thing, is that what happens to the foramen ovale in the third trimester, we need to pick out that group who will have a restrictive foramen ovale, because these really need, in terms of immediate balloon septostomy. And I think that becomes an important point more for second trimester talk on TGA, is trying to screen out those poor performing TGAs by virtue of foramen ovale restriction. So if you look at TGA, if the incidence of congenital heart disease is 8 to 10 per 1,000, that's a hard figure to remember. You should say it's around 1%. And of those 1%, half are major and half are minor. And if those are major, the 4 big ones are TGA. So that's all cardiac CHD there. And then the TGA, to add added complexity, TGA is not one condition. If you look at the Masudi, which is a pathological classification of TGA, the actual relationship of the aorta, which is in blue, to the pulmonary artery, which is in white, is actually quite variable in TGA. And this becomes relevant because from a surgeon's perspective, they will look at these positions and they will look at them, some of them favorably and others less favorably. And why is that? Because where the coronary arteries arise will actually is dictated by the relationship of the aorta to the PA and the complexity of the surgery that's involved. And it's worth reading Dario Palladini's done a nice paper on STIC volume and 3D trying to predict which of these subtypes and their prognosticate TGA versus a favorable coronary artery position for repair versus one that's going to be tricky access to take off a patch and transpose during postnatal repair. The sonography, I always find that's easier to do this by virtue of diagrams rather than in text. So you can take a snap of that, and then I'll just move to the diagrams in the interest of time. The fourth chamber may be completely normal, or you may see a VSD anywhere along the septum. It may be along the lower septum, or it may be a perimembranous. You see a drop out in the septum, look for edge enhancement, and then look for a color wash. The 3 key ingredients, in a sense, you need to make a call of VSD versus a false positive call of dropout. Then when you turn to a 5 chamber, you may see both vessels coming out in parallel, or you may see that the vessel coming out of the left ventricle branches. Well, that's very abnormal. It shouldn't branch. It should take an arch and go up to the head and neck. Or you may find that the left ventricular outflow tract looks dilated. And in fact, some TGAs are referred to our units saying, Simon, could you please have a look at this fetus? I think it's got mild aortic stenosis, but I'm not seeing the turbulent flow. And in fact, what they're seeing is there is dilatation of the left ventricular outflow tract, but the reason it's dilated is because it's the pulmonary trunk. If you actually look at a normal heart, the pulmonary trunk is much bigger than the aorta at the point where it leaves the heart, the level of the valve. So, in fact, that may be a clue for you. If you're ever thinking pulmonary aortic stenosis, remember in your differential that it could be TGA. The other feature is when you think of it, that the vessel that's coming out of the right ventricle is not the pulmonary arteries, the aorta. If you actually look at, and this is an exercise that's worth doing when you go to work tomorrow morning, if you take inflow into the right ventricle and then you fan the transducer to the head, the curvature of the vessel coming out, and here's your aorta and SVC in your three vessel view. If you actually sweep from a 4-chamber to a 3-vessel view, you will see the curvature of the normal curvature of the pulmonary artery coming out of the right ventricle. It's important to do that. If once you've done that 100 times, and it's worth doing it, once you've done it 100 times, you know exactly how the pulmonary artery is related to the 4-chamber. And you will instantly recognize TGA if it comes around to you, because when you sweep, the strangest thing happens is you sweep, you find up to the neck, you find, well, here is the 3-vessel view, aorta and SVC. You'll say, oh, hang on, that doesn't look right, because the vessel coming out of the right ventricle has actually got reverse convexity. And that's a very useful marker on top of the others I've just mentioned. The next one is you move, and I'm going through this in order of the ischioc 4-chamber, 3-vessel tracheal, the ischioc section analysis. The next section up is to look at the 3-vessel and tracheal view. And when you come to this section here, you will see that there's only 2 vessels. Why is that? Well, because the vessels are transposed, the aorta is actually anterior, because you know normally the pulmonary artery sits on top of the aorta. Well, it's the reverse. The aorta is the most superior vessel, and therefore it's not up there. The duct is not up there. So you've only got 2 vessels in your 3-vessel tracheal view, which is the aorta and the SVC, because the pulmonary artery is sitting inferiorly. The last one, the sagittal arches. I've never picked up a TGA by finding everything else being fine, and the sagittal arch, I found that the ductal arch is giving off neck vessels. You know that the ductal arch should never give off neck vessels. It's the most superior arch. And if it's the aorta, because they're transposed, if you see that the ductal arch is in fact the aortic arch giving off neck vessels, then it's TGA. But for me, I don't find that helpful. When I do demonstrate it in my report, I take a sagittal view and show that the ductal arch is in fact not the ductal arch, it's the aortic arch, but it looks like a ductal arch and it's giving off neck vessels. But by that stage, I've already seen all the other signs. So it's like an icing on the cake sort of thing. What I'm saying is in a screening context, sagittal arch imaging pays off very poorly to the point that we actually don't routinely look at the arches sagittally in imaging. We rely on the 3-vessel tracheal view. That's by far more powerful section than looking at sagittal arches. Sagittal imaging only comes into view in the setting of cardiac malformation. I don't know if I'd be interested, Fred, just to hear your take on that in the UK, whether imaging the arches sagittally is in routine practice. Anyway, continue. It's not. Okay.
No.
Okay. So next, let's move to the first trimester. So in first trimester imaging, the first thing you're looking for is axis deviation. Now, axis deviation, I know the big ticket item I said to you is the co-truncal. Again, by virtue of numbers, that was in that study, but also you would expect by virtue of numbers and TGA would be up there, and it is. So axis deviation is a marker as well for transposition of the great arteries. The next is in terms of looking late in pregnancy is looking for signs of pulmonary stenosis and Doppler high velocity flow, and I mentioned COARC. So now I'm just going to start off with just showing you an example of a section analysis sweep and looking at those markers at 18 to 20 weeks. And then I'm going to go to the first trimester. So as we sweep here, this is the stomach here, and this is the aorta, which is the left spine, and the IVC, which is anterior and to the right. That looks normal. I then sweep up to a 4-chamber view of heart, and we then freeze the 4-chamber view of heart. and the descending aorta defines the left atrium. So that's the left atrium, that's the left ventricle, that's the right ventricle, and that's the right atrium. So we've just got our bearings, see where everything is. And then next from that, we then sweep up, and the next we expect to see is a left ventricular outflow tract, that sigma curve of an LVOT. And as we sweep to the left ventricular outflow tract, we find that it actually splits. So as we look at this point here, damn it. When we look at this point here, it's just about there. When we look at this point here, we see that the vessel coming out of the left ventricle actually splits. Well, that's very abnormal. You have to see it in 2D and color. Just freeze it there. So this is the LVOT coming into view. And as it does so, the LVOT splits. Well, that's very abnormal. Remember, it's very important that when you're scanning a heart and you're sweeping, when you leave the fourth chamber, the first vessel you should see is the aorta coming out with the aortic valve. Just remember that. The aorta should always be the first vessel that you see in a sweep. The last vessel is the pulmonary artery because it's the most anterior vessel. If you crack a chest open and you look at the heart, you see the pulmonary artery. You then keep going up the chest. Just bear with me. It's just
I think it's fine. So we just need to wait.
I just go to Task Manager and
I think we have so many clips because in yesterday presentation I had about 200 clips, so that computer can't really
cope with it.
deal with this. Yeah.
Yep.
This is the problem.
That's okay. It's come back quickly.
Yeah.
So as you sweep next up from that, you then move from the vessel that comes out of the left ventricle, which bifurcates. I'll just let this clip play out. And then as you sweep up next, you then see the reverse curvature. So you would expect coming out of this right ventricle, you would expect the pulmonary artery come out like so, aorta and SVC. That's what you would expect. But when you look at the vessel, a little bit of tricuspid valve regurgitation as well. You look at this vessel and you sweep, you're now keeping your eyes. First of all, you're seeing this branching vessel, and now you've got the right ventricle, and you expect the pulmonary artery to come out in this direction. But as you're sweeping up to the three vessel tracheal view, it sweeps in the opposite direction. And not only does it sweep in the opposite direction, this is the SVC, but there's no V here, there's no arterial duct. So that's an axial sweep at the mid trimester. And I want to show you this by doing showing you the right ventricle in view and doing a split image with showing you that reverse curvature. You know that the pulmonary artery should come out like so with the aorta and SVC, and it does so in a reversed direction. And similarly, in this case here, you know that this should come out like so with the aorta and SVC, but it actually comes out in a reverse direction. Another example, a four-chamber view of heart, you sweep, and it should come out like so in blue, but instead it comes out like so. So that's just a very useful clue for you in the first trimester of pregnancy, and I might just skip these in the interest of time just to catch up. Remember, in terms of first trimester and in second trimester, the power of using high-frequency transducers. So as we look here, we see the LVOT, and we look here, see the RVOT. It all looks absolutely fine until you realize that they're coming out in parallel. So I haven't gone further up to showing you the bifurcation of this vessel into the duct and the branch pulmonary arteries, but I have just shown you the parallelism of the vessels. And that was the last sign which I wanted to show you that's important also in the first trimester of pregnancy. And I'll skip the stick render. So let's move now to the first trimester of pregnancy. So this is a features at 12 weeks of gestation. You can see the four chamber and you can see the ventricular film. And as you sweep up to the three vessel tracheal view, you see the reverse curvature. And here, bottom left-hand corner, you now magnify the image and you see the normal ventricular film. Your PRF is set 30 centimeters a second in this case. So it's around a 13-week scan. And then you sweep up to your three vessels and you see that reverse curvature. Now you may find if you don't go high enough, you may find that you get both vessels. So you can create the appearances of the two vessels just coming in side by side, but it's the curvature that will always be abnormal. And it's the point I make by using stick TOI that I can show you a normal three vessel tracheal view by virtue of the V sign, but the curvature will always be abnormal. In this case, in the bottom left-hand corner, as you see the ventricular inflow. And as you sweep to a 5-chamber view, you see the vessels are in parallel. So this is the other sign is the sagittal, sort of parasagittal 5-chamber. And then you sweep up to your 3-vessel tracheal view. The both vessels are there. And then finally, the pulmonary arteries, you go higher. You see the pulmonary artery disappears and you have the abnormal reverse curvature, or what we described it as being the boomerang sign, because the boomerang should come out in this direction out of the right ventricle. And the same thing you can do is showing a stick volume, showing the ventricular fill. And here you have both your arteries coming out in parallel, and that's reverse curvature of the aorta coming out of the right cardiac ventricle. And you can do that by comparing to what it should be. So this is a stick volume acquisition. Here's the aorta, which passes underneath, and the pulmonary artery, which is on top. So this is a normal heart and a stick volume sweep. And this is a abnormal on a color stick volume. But again, it's not a 4D diagnosis, a 2D color diagnosis. Next case, number 3, a thin nuchal translucency, normal cerebral fourth ventricle. And then we come around to looking at a 4-chamber view of heart in the bottom left-hand corner. We see normal ventricular fill. And then we sweep to the 3-vessel tracheal view. There are only 2 vessels. So the V sign is not there. And then you can see that reverse curvature of the right ventricular outflow tract. Move on. This is the same case. And this is doing a split image. And again, this is what we do in the first semester in sonographers training in our unit, is they learn to get a split image showing a 4-chamber and a 3-vessel tracheal view. And once you've done 100 of those, you then understand the relationship of the vessels to the 4-chamber. It's so important to have that spatial understanding. And it takes a long time to learn it in a sense, but once you get it, it'll stay with you for the rest of your life. On this here, stick volume, as you sweep, you can see the parallel vessels, and then you come up to the 3-vessel tracheal view, you see the abnormal curvature, you can still see the MPA, and now as you go higher, it disappears. So to see 2 vessels on the 3-vessel tracheal view, you really have to go into quite a high position to get that. The other thing is on seeing that parallel vessels, it's not always the 5-chamber, it's actually coming around to the sagittal arches that you may demonstrate. It's a slightly more oblique plane, and you can see that demonstration of the vessels coming out in parallel between a 5-chamber, 2 arches is what I'm saying. Next case is at 12 weeks of gestation, a thin nuchal translucency, thin nuchal, that's the amnion. And then you look to see the 4th ventricle. As you go to the 4-chamber view of heart, you can see there's cardiac axis deviation. So next you go in and you magnify. This is starting with transabdominal. And as you sweep from the 4-chamber view, you appreciate on 2D that there's something not right about the cardiac outflow tract. So the next is to put on your color. And as you do so, on the frame on the left, you see there's that abnormal curvature, reverse curvature of the right ventricular outflow tract. When you put on color, you can't see the V sign. This is your ascending vessel coming out the left ventricle, which is your pulmonary artery. And then you come up to the 3-vessel tracheal view and you only see 2 vessels. In the same fetus, the ductus venosus was reversed, which made me very suspicious because I wasn't expecting that in the setting of a thin nuchal translucency with TGA to see a ductus venosus reversed A wave. This is more footage of the same patient. And as you sweep, and then you come up here and you see just the 2 vessels on the 3 vessel. And then you do the same thing with color. So you go to the 4-chamber view of heart, you look with color and you sweep, and you can appreciate on 2D, there's only 2 vessels and there's reverse curvature. Now you have to demonstrate this in color. So you look with color, you see that there's symmetrical inflow, no tricuspid valve regurgitation. And then you sweep from that out to a 3-vessel tracheal view, and then you see just 1 vessel, and you go back and you repeat again onto the 4-chamber. Next one, you see that there is a pleural effusion. You see that there is cardiac axis deviation, left axis deviation, and then you sweep from a 4-chamber up to a 3-vessel tracheal view, and as you do so, you see that reverse curvature and only 2 vessels on the 3 vessels, same as all the others before. And these are all the typical features of TGA in the first trimester. This fetus with the pleural effusion also, had hyperechogenic kidneys, and also had polydactyly. So in the setting of seeing transposed great arteries, polydactyly, echogenic kidneys, you need to be mindful that it may not necessarily be transposition of the great arteries, there may be transposed vessels in the setting of a double outlet right ventricle. And this is where refining diagnoses, in a sense, becomes difficult in the first trimester. And in the setting of seeing polydactyly with hyperechogenic kidneys would make me entertain that as an important differential diagnosis in that setting. And then here, a nice example of it a little bit later, I think this is, 14 weeks, you see a 4-chamber view of heart, just your reference there of a centimeters from here and to here. So it's just over 13 weeks, just outside the first trimester. And as you sweep, you see the boomerang sign. So you sweep from a 4-chamber up, and you see that reverse boomerang. So this is the aorta coming out of the right ventricle. And that's why I take that very abnormal curvature, because if it was the pulmonary artery coming out of the right ventricle, it would be like so. Let me draw it with its branch. It would be like so, giving off the branch pulmonary artery. And then you'd have your aorta and SVC. That's what it should be. But it's the reverse. And actually, just at that point, I'm going to be careful, don't freeze the machine. But just at this point, you see the aorta, and then inferiorly, you can see coming out of the left ventricle, the bifurcating pulmonary arteries. I'll be very careful I don't, there they are, the bifurcating pulmonary arteries inferiorly. And then this is the same patient just using color Doppler. So if you look with color here, you see the normal inflow, and then you sweep to your 3-vessel tracheal view and you see the reversed boomerang. So these are the markers, 2-vessel and the 3-vessel tracheal, and then you can move to doing the same on a 5-chamber view. Between the 5-chamber view and the sagittal, what I call slightly parasagittal. And that's probably the best position to demonstrate parallelism of the vessels arising. If you just simply take the 5-chamber view, only a small proportion of features will present with parallelism. But if you actually rotate around between a 5-chamber and a sagittal, a much higher proportion you will demonstrate, particularly with stick technology, with wide slice VCI, you will demonstrate that. So on making a call, you of transposition of great artery in the first trimester, you check for associated abnormalities. Be mindful that there is a significant proportion of them, 40% will have VSDs, and they may be difficult to exclude in the first trimester. Check for outflow tract obstruction, although this is unlikely to be picked up in the first trimester. As I said, this is more a 3rd trimester call. For most TGAs, they do occur in isolation. If they are associated with an increased nuchal translucency, there's no question you would move for CVS and go to FISH. For some patients, they know the association with TGA, excuse me, with chromosome abnormality is so low that they actually don't want to take the risk of CVS. So we see them at the pediatric cardiologist. They're cancelled. They want to continue the pregnancy. The outcome is favorable. It's one of the cardiac major outflow tract anomalies that carries probably the best prognosis when compared to the others. And most patients choose to continue the pregnancy in our unit when they're cancelled. But when the diagnosis is made in the first trimester, quite a significant proportion will make a decision to opt for amniocentesis, and that's for not just TGA, other cardiac malformations. So always bear that in mind. Just because you've made a diagnosis of a cardiac problem in the first trimester doesn't mean that you have to, in a sense, push your patient down the track of having a CVS. Always consider that an option of having an amnio, which carries a much lower risk. And some patients even make the call, although I don't encourage this, but they make the call of having an NIPT and then a later amniocentesis. But, that's not something that I encourage. It's more comes up in conversation. Some patients do choose that, but it's not recommended. And be aware that TGA is just not one condition. There are many different subtypes. We can't classify those in the first trimester. That's really a second trimester assessment, and even then, it's challenging in using 4D technologies. I still think we're far away from being predictive in the subclass, Masudi subclassification of prognosticating into difficult coronary artery repair at the time of an arterial switch. And I might stop at this point, I think, Fred, and hand it open to the audience for any questions.
Yeah, it's great. I think at least I can't see any question. Just a second, I will appear. So 1 sec. Yeah, so I can't see any questions now. 1 second. Somehow you can't see me.
Anyhow, I look forward to seeing you all hopefully at the upcoming next ISUOG online series. If you can join us.
Oh, sorry, Simon.
Okay.
So thank you very much for this fantastic presentation, and it's really great. I can't see any for you, and I think in Melbourne is about 1 o'clock, 2 o'clock.
It's 11 o'clock.
11 o'clock. Oh, okay.
Yes. Yeah. I was actually for Fred. I actually got my hours a little bit mixed up, so it's much better than I thought. Yeah.
Yeah, great. So thank you very much. I think we will give now the voice to talk to Peter, and
Yes.
Peter can give talk about a new development of Wolusan, because and I know that this is fantastic lecture, and probably Peter, you will be able to answer for some technical question regarding slow flow. Please.
Yeah, thank you, Fred, and also thank you, Professor Meager, for the great lecture, because that's also what you showed, also the images, and also Fred, is that new technologies, they also have the clinical value when you use them in the right way, and also, of course, it's not only to make pretty pictures. Of course, I will show some very nice pictures, but it's very encouraging. For example, slow flow. You also were talking about B-flow, one of my favorite technologies from the past. I still remember the B-flow stick that we could make, but also slow flow HD, but also radiant flow, and of course the latest transducers. Because if you have the transducers, for example, high frequency transducers, they're like the 9L in the past. This transducer was used for vascular imaging in adults for the carotid, for example, but also for some MSK work. But then we noticed that with these transducers, especially the 9L transducer, and I will show you some images also, is that this transducer was really, and is still a really great transducer in obstetric, also in the first trimester. And I still remember I think it's more than 10 years ago that we started to use the transducer on systems, and that's really great. And I know a lot of the tendencies, they have a lot of transducers. And I also would like to encourage you to have a look. So what I always do when I do a training for Voluson, that I want to start as high as possible in frequency, and then you always can go down. So that's always my takeaway of what transducers you have. Always start with the highest possible frequency, and then it's always possible to go down, but start as high as possible. So hopefully you can see my screen. Yeah, so for example, what we did on the Voluson E10 for the BT20 release.
Not yet, Peter, that your screen hasn't come up.
Okay, so let
We
me.
can't see you. Sorry.
I might not be able to stay for the rest of all of the talk, Peter, but I would just like to thank Fred very much for the invitation. And Fred, if I could ask if you could please share Peter's talk with me tomorrow, if that's possible.
Yes.
I would love to see it.
We will send the link, and you can see your talk and all the talks.
That'd be great. Thank you very much. I'm going to stay for a few minutes and continue to watch, but the late hour is calling. Sorry to interrupt you, Peter.
Oh, no problem. I totally understand. So I have to say good evening. We just started the afternoon over here. So you can see my screen now, Fred?
No, unfortunately.
I will try to share it again.
We can do differently, because we can do some break anyway. We need to give break for our participants, and you can something going. Yeah, fantastic.
Yes.
Fantastic.
Okay, perfect. So let me start. So I will just open it again. So as you can see over here, what we already discussed. So I will show you some new latest technologies that we introduced on the Folloson. So I will focus on the Folloson E10 and just introduce some new technologies from transducers. So for example, we introduced the the C2 to 9 transducer as a high frequency abdominal probe. What you need for your diagnosis, of course, and that's wall filters of the signal. So you know, I think when in the for detecting flows. So I would really encourage you, if you have it on the system, to try it in different applications. So that means that the vessels will be more transparent. Over here, you get the coronal view. So the 3D 4D probe. And if you have this probe, and also what I just explained to you in the other slides, is try to do this VCIA, for example. When you have the RM6C probe, press 4D and try to find the VCIA image. This one, a lot of images you already saw it yesterday and today, the RSC 6 to 12 probe, the high frequency and the vaginal probe over here. And look at this one. So also with the slow flow HD, here's a nice 3D 4D image. And then this probe, the 9L probe. So this is a linear probe, but with a very high frequency. And what you can do with the linear probe is that if you scan with it, and you can see on the touchscreen, it's called virtual convex, but that means that a 3D appearance of the flow, but also in this early scan over here. And then the slow flow in early pregnancy. You can see over here already that the background, maybe there's less background, so you can even have the background totally on, that you can just see it as what you normally would do with color. But also have a look if you turn on and off the background over here. And this one, a very nice early pregnancy with the slow flow. And also what we noticed is that if you use slow flow and you just go down with the acoustic output, also your tissue index is really low. So, and of course, we scan with the ALARA principle, of course, as low as reasonable achievable. But have a look if you use slow flow. That's very interesting, because if you have a low acoustic output, also your TI is on a very low level. So that's also interesting to use the slow flow. Also, what we see now in ultrasound, but also with Folloson, is to use more semi-automatic technologies. So the first thing that we did, I think you can remember that we had Sono NT technology that automatically you get a measurement of the NT of semi-automatic. You just hold the probe and then the sweep is made, and then it will automatically find the planes according to the ESOR guidelines. You can even with your phone go to this QR code and then automatically go to the guidelines over here. And you see also automatically the measurements are done. So a very interesting and really good technology. So just try. So if you have the Folloson BT19 or BT20, then the Sonos CNS is part of the system. So it's not an option. So it's already embedded in the machine, in your Folloson. So that's the Sonos CNS. What I would like to do is, of course, now we are facing some travel restrictions, of course, from my side. So I can travel to some countries, and also that gives us some challenging sometimes in application support. But what I would like to ask you is, if you have time, of course, try to, on your iPhone, try to download the GE Star app. Just go to open for any questions. So
to you regarding ALARA principle in first semester about slow flow and radial flow.
Yeah.
Please, can you answer?
Yeah, so let me check. So question and answer. So let me just.
Yeah, this is what
Even yeah, no, perfect.
Okay, so thank you,
Thank you,
Peter,
Fred.
and
Thank you.
thanks for everybody listening us. So what we will do now about 15 minutes break, and after I will continue with presentation because we have more information for today. So a 15 minutes break. So thank you. Presentation because I was thinking that Simon will do what he did because Simon gave absolutely amazing presentation how to do e-echo, how to scan the heart by extra definite scan. So how to get all the views which are typical or not typical, how to get the most possible information from the baby at 13 weeks. And I agree with him that the best time to scan is end of 12 weeks and 13 weeks. And the best route is transvaginal scan. I have different ways how I'm doing this technically, but I agree completely with everything that he's telling in his talk. But this is talk about echocardiography. This is talk not about screening. And I will try to show this presentation now from point of people that are not experts, but they don't want to miss heart abnormalities. So this is a different way of talking. So this is screening what we were talking yesterday. This is presentation from FMF about 1,100 cases scanned by 500 different doctors and sonographers. So how they can perform scan, mostly transabdominal, not to miss heart abnormalities. And some of the clips I will show you transvaginal, but actually all the clips are old. There is no any new clip in this presentation, specifically not any clip, because I want to show that everybody can do this, not what Simon can do. What Simon can do, maybe, I don't know, 100 doctors in the world, they can do this quality of imaging of the hearts at 13 weeks. But what I will show you, everybody can do technically using not new machines because clip were performed by old machines many years ago. So, and I will show you what I think the correct way how to check heart structures and how to try to detect anomalies and after to send for somebody who knows how to scan. So I think the important word in my presentation, I think you can't see it, but important word in my presentation is patterns. So I will show you patterns of the heart, abnormal patterns of the heart that if you can recognize them, they know that you need to refer. And second thing that I need to show you is I'm talking about screening. So I'm talking about screening and patterns. Yeah, patterns and screening. So let's go. Okay, and I think I am interfering with this image, so I will run this way. Okay, So you can see this presentation, I hope. Yeah, wow. One second. I need probably to. Okay. Just 1 second to do a full screen. Okay. So 1 second, okay? Well, because on my screen, I'm not sure that I'm showing this well. Okay, so what can I show you, and what I would like you to see, that there are two different scans of the heart, as we were talking yesterday. First is for screening of the congenital heart disease, and this scan is for all pregnant women, I hope in the future. This scan will be integrate part of the 13 weeks scan, and it's supposed to have standard protocol. It's supposed to have absolutely clear referral pathways. It's supposed to have absolutely clear framework, and this is for doctors which are screening doctors or sonographers. So this is the this is the thing that we need to do. So, and it's supposed to be fast and easy. It's supposed to be transabdominal, and it's supposed to have just very simple way of scanning. So you really need to be very to have very simple way of scanning, to have this type of imaging. And second is early echocardiography. I will not talk a lot, because actually Simon showed everything today what is possible to do from point of echocardiography. And today's lecture will be about patterns of the heart, and it will be about screening. So this is not the lecture about echocardiography. And what we need to know is that when we are scanning the heart, what will be abnormal pattern, and what can be abnormality. So first abnormality that we can see is abnormal for chamber view. Abnormal for chamber view, it's quite easy to recognize. And abnormal for chamber view from point of common abnormalities, and we're talking about common abnormalities today, is actually 4 different conditions. But from those 4 different conditions, the most important condition is so-called functionally univentricular heart. What does it mean, functionally univentricular heart? It means that, practically speaking, after delivery, the baby can't have repair to biventricular heart. So it will be univentricular repair. And this is prognostically very bad finding. So it's if it's a hypoplastic left heart, if it's the hypoplastic right heart, if it's AVSD with a disbalanced ventricles, so you can't create. So all those conditions actually on scan, they will have univentricular heart like this, and actually functionally they will be not able, those babies will be not able to have repair. So this is a significant abnormality. Second thing that you can have, it's a difference between size of the ventricles. And the most important thing, actually, not to mismatch, not to make mistake between disproportion and univentricular heart, because prognosis can be completely different. And cardiologists really not happy with us if we're making those mistakes, because from point of prognosis for them, it is extremely important, the difference between those conditions. Third thing that can happen, it's a major septal defect. So usually it is or major AVSD or major VSD that you have impression that there is just, it can be impression that there is just one chamber, but actually those are septal defects. And fourth condition that it can be at Epstein syndrome or other problems with the like tricuspid dysplasia. So all those things are creating abnormality of the four-chamber view, and abnormal four-chamber view, if we are not talking about septal defects, usually has prognostic finding, because if you are talking about univentricular functional univentricular hearts, so the prognosis will be not good. And fortunately, we are able to recognize those cases in first semester much easily than other cases of the, like Simon was showing with the tetralogy of Fallot or transposition of the great arteries. So this is list, and will not stop here. This is list of different conditions that can be, the end of those conditions will be univentricular heart. So I think if somebody can see the last word, I can jump here. Okay, I can jump here. So, univentricular heart. So those conditions can't be repaired for full biventricular repair. So this is functional univentricular heart. So you're scanning at 12 weeks and you can see single ventricles. So you can see two vessels at forward flow, but just one filling of one ventricle, as you can see here, the red, and this is blue, the outflow tract. So in this case, what can you do? Of course, you can scan like Simon, but what I recommend is to refer this lady for echocardiographists, for cardiologists, for echocardiography, because this is significant finding. And if they will confirm this single ventricle, so actually it's not important which type of abnormality. Big proportion of the ladies, they will think about if they want to continue the pregnancy or not. So this is different because you can make a major mistake, and how you can make a major mistake is that you will think that this is univentricular heart. We have, and not just we, other units also have the cases that people with this type of image thinking that we are talking about hypoplastic left heart. And I agree that it looks like hypoplastic left heart. So as you can see here, okay, 1 second. I lost my, oh yeah. So you can see here that there is a ventricle, and you may think that it's a hypoplastic left heart because actually there is one big ventricle, and second ventricle, this position is not really good seen. But if you will turn in transducer and you will run scan in this. Of course, this is not the best cross-section to get, but you can see filling of the left ventricle. You can see severe TR here. So practically speaking, we're talking about two ventricles, and you can't tell that this baby has hypoplastic left heart. And actually, this baby can have coarctation of the aorta, and with follow-up scans, we can see the growing of the left ventricle, and it can have absolutely different prognosis. But of course, this case is supposed to be referred for fetal echocardiography and counseling by cardiologists. So if you can see this finding, refer the lady, because it's important to her to be seen by cardiologist. So in many cases, like I showed before, and a case like this, the diagnosis is not possible without color Dopplers. And I am really very happy to hear from Simon, because Simon probably involved in this new preparation of the guidelines about cardiac screening, that next ESOC guidelines will include screening for hearts in first semester by color. So if they will do this, so actually it will be amazing. It will be the one of the amazing things that happen in development of the early fetal scan, early detection of the abnormalities and early detection of heart abnormalities. So AVSD, yeah, AVSD has abnormal for chamber view, and you can see it's clearly. I will show you a little bit later how you can detect AVSD. But AVSD by scanning of the heart, if you're trying to detect, even if you're trying to do tricuspid regurg, practically speaking, you're supposed to see a big AVSD because there is no tricuspid valve. So how you can do tricuspid regurg if there is no valve. You can see single valve opening like those this way. So from point of arteries, abnormal arteries, I think it's for doctors who are doing scans, again, not echocardiography, doing screening scans in first semester. The important thing is to make some simplifications, because I will show you next slides that actually will stress you, and because there are so many different findings. So I don't think that we need to see all those findings, we need to see all those findings, but doctor who is, or sonographer who is doing scan in first semester may not recognize all those 200 different heart conditions, because maybe she or he never heard about this. And it's absolutely correct, because we are not cardiologists. I'm not cardiologist. So some conditions that I'm talking about, I just scan somebody, I've seen this condition and learned from this condition. I had no special training as a cardiologist. So it's completely understandable that you may not recognize some of the findings. So from point of scan of the arteries, so the simplification is supposed to be first, this big overriding vessel. And the lecture that Simon showed first is exactly about this. One vessel in the middle of the heart and it's coming from this. So, and you need to understand that it's abnormal vessel and not to miss, because if we'll come back to the statistics of the research of FMF, so big proportion were missed in the cases that I think actually probably it was detectable. Second, they are parallel arteries, and parallel arteries, it's usually it is a transposition of double outlet right ventricle. Small aortic arch, quotation, and vascular rings. Vascular rings are important, but today we will not talk about vascular rings because it is abnormality of the heart, but it's not abnormality of the heart itself. It's variation of the vessels, practically speaking, and we'll talk about these findings next Saturday. So there are different ways how research published the experience in detection first semester, and this is a very good article from Marcin Vehic that they described patterns of the hearts, and I think the word pattern is very good. It's correct to describe patterns of abnormalities, not abnormality itself, because specific abnormalities of the heart have specific patterns, and they describe those patterns. Which are quite complicated, because they were talking about patterns of filling of the ventricles and patterns of the vessels. And this is much more complicated table, which is actually coming from a group of Simon Marr that just was talking in the morning or his evening, night. And he created this table regarding different variations of the outflow tracts. And if you will see all those variations, so actually you are feeling very, very stressed, because it's really complicated table. So I think that both approaches of Marcin and Simon are correct, but I have my own approach, which I think is better. Well, I think it's better because it's extremely simple. So it's very simple, and I will show you that what I think we need to do. So there was the guy by name Pareto. The guy was Italian, and he lived about 100 years ago. And Pareto finds so-called Pareto principle. And this rule talking about that actually you if you are doing so for many events, roughly 80% of the effect come from 20% of the causes. What does it mean? It's exactly principle of screening. So actually you're trying to pick something that's the most important and spending for this small amount of resources. And other things that less important, you are losing it's okay. So it's principle of screening, and it was probably developed by Pareto without any connection to medicine. But if you are talking about principles of Pareto in application or to the screening of the first trimester anomalies, and not just first trimester heart anomaly, second trimester too, actually what you can see that there is 5 common abnormalities of the heart that together, all them together is more than 80% of all severe heart anomalies. So you don't need to remember and to learn so many heart abnormalities that you will never seen in your life. Because to see one severe heart abnormality, you're supposed to do about 500 scans for low risk population. So many of severe, not severe, rare abnormalities you will never see. I never seen some of abnormalities that even that I've seen a lot. I really seen a lot of heart problems, but some of them I never seen, and I even don't know that they are existing. So what are those abnormalities? Very easy. Transposition, tetralogy of Fallot, AVSD, apoplastic left heart syndrome, and cortation of the aorta. Together, 83% of all severe heart disease, and this is from EuroCut website. So, and again, if we're talking about severity of those conditions, those conditions are in group of severe conditions, and they are in 2 groups, hypoplastic left heart actually in the group of more severe conditions, and other conditions are mostly in group 2, but also all those conditions baby supposed to have surgery after delivery. And if we are coming back for this publication that we were talking yesterday a lot, you will see that the conditions that are more severe and related to single ventricular repair were detected with very high detection level by research fellows of FMF. And conditions that were severe but less severe and associated usually with biventricular repair were detected in less than 50%, but also with some good detection rates. So, and I suggest this simple algorithm without any transvaginal scanning. So this is the baby at 13 weeks. Just a second. So this is the baby at 13 weeks, yeah? So, and this baby is lying on the back, so you don't need to do transvaginal scan from side and to try to turn the image differently because this baby is lying on the back because you are doing transvaginal scan for this baby. So easy. So you are doing transabdominal scan, not transvaginal, transabdominal scan for this baby because you just measured nuchal translucency and also CRL. So you measured nuchal translucency, CRL, rotated transducer, and you are getting this image of the heart. And on this image of the heart, what you can see filling of 2 ventricles, and you can see this V sign. So you can see right ventricle, left ventricle, pulmonary artery, and the aorta coming from different sides. And what I suggest, and this is the scan that I did for lady that she had previously baby with undiagnosed transposition of the great arteries. So she delivered baby after baby got blue color and after collapsed. So, and this was after a completely uncomplicated cause of pregnancy in the middle of small town without any possibilities of transfer this baby immediately to the hospital. So it's fortunately this baby has also VSD, so it was transferred urgently to cardiological unit for treatment. Yeah, so and it was saved, but In other cases, baby can die in 15 minutes if you're not, if you are missing transposition of great arteries. So, and she came back really worried, and this is just 6-second clip. So very, very short clip that's showing you the feeling of the ventricles and arteries. And you're asking yourself 5 questions. Just, is it hypoplastic left heart? And you're saying, wow, no, I don't think that it's hypoplastic left heart because I can see left ventricle filling by blood. So if left ventricle is filling by blood, so probably it's not hypoplastic left heart. And also I can see actually the aorta because I supposed to know that in the hypoplastic left heart, it's difficult to see aorta and there is reverse flow in the aortic arch. So I can see it here. So this is not hypoplastic left heart. Is it AVSD? Yes, it can be small AVSD because small AVSD will be not detectable on this clip, but large AVSD will have so-called trousers. I'm calling this, it is trousers like this feeling of the ventricles. And I will show you how it looks, but you're supposed to recognize big AVSD, and also you'll see this opening of the valves like those, yeah, opening like this. So you're supposed to recognize this. And if it is tetralogy of Fallot, and Simon was talking a lot about this condition with fantastically good images and examples. But what I found for myself scanning babies with tetralogy of Fallot, that actually for tetralogy of Fallot, real tetralogy of Fallot, it's very difficult to see pulmonary artery. So if you can see pulmonary artery like this, and here you can see pulmonary artery, just 1 sec. So pulmonary artery coming straight down like this and with continuation of the ductus. I personally never seen real case of tetralogy of Fallot having this good artery at 12 or 13 weeks. So for tetralogy of Fallot that I've seen, for me was difficult to detect this artery, to detect pulmonary artery at all. And I did scan later and I was able to see, but not seeing this good artery. So this is not tetralogy of Fallot. And you're asking, okay, fine, so it's not tetralogy of Fallot, but maybe it's a transposition. But again, this is not transposition. Why it's not transposition? Because the second vessel that coming from the other side, so on the same view, I will try to stop this image, 1 sec, and I will show you. So it's coming this way. So, and this is aorta. Actually, it is crossing this artery. So this pulmonary artery coming from the right ventricle down to the aorta, but second vessel is coming from the side, from right side and connecting to the aorta. So this is not transposition, and we'll talk how to detect transposition because the lecture of Simon was very good, but I would like also to show experience because I think it's easy to detect transposition, and there are 2 different variations how you can. There are 2 different variations of the connections of the transposed vessels, and both are possible recognized. I'm talking about just first trimester. So this is not transposition because aorta went to the right and after is connecting to the descending aorta. Is it coarctation? So coarctation is more difficult. Coarctation, this is questioned because you know that some coarctations are not detectable even by cardiologists. So the coarctation from all this list is the most difficult. I will show the signs that actually you can help you in diagnosis of coarctation, but it is not so easy. And if it's not, so if it's not, so it is normal heart and reassurance. Why it's reassurance? Because majority of defects of the heart are those defects. And if you are saying, okay, Fred, you're thinking that there's defect, for instance, double outlet right ventricle. Yeah, but if double right ventricle, so you will see something that it can be similar for Fallot, or something that it can be similar for transposition, or something that it can be similar for hypoplastic left heart, because actually there is a big disproportion between ventricles. So probably you will detect by this algorithm more conditions. So, and how it works, from point of view it works, we have statistics now. So we know that if you are looking for hypoplastic left heart, because it's interesting that ISHO can present in old guidelines that I hope that will be changed. They're talking about that late development of some anatomical structures and pathologies, and they're talking about corpus callosum that, okay, corpus callosum is not present in first trimester, clear. So all the attempts to find corpus callosum in first trimester useless because it's not present. But they are writing about hypoplastic left heart, that is something that is not present. But we have now statistics of FMF. 93% of hypoplastic left heart were detected. I'm not talking about present. They were detected in first semester. And I don't remember the numbers, but it's huge amount of cases. It's not 3 cases, it's many cases. So those are detectable. And those are detectable. Why are they detectable? Because those conditions have abnormal for chamber view. AVSD detectable, yeah, detectable. If you're talking about tricuspid, they have quite many cases of tricuspid atresia. Yes, it's detectable because tricuspid atresia will have abnormal looking for chamber view. So it will be also detectable by this simple algorithm. So let's talk from point of, again, it's not fetal echocardiography. We're talking about screening for heart abnormalities. So hypoplastic left heart, so hypoplastic left heart is not one condition, it's a group of conditions, but the outcome of those conditions is that the left ventricle is very small, there is mitral atresia, or there is some severe mitral stenosis with regurgitation of the blood coming through the valve and back. You can't see the aorta because there is aortic atresia. And the most important thing that the feeding of the aortic arch is coming through the ductal arch. So ductal arch and after retrograde feeding of the aorta. So this is the typical typical appearance of hypoplastic left heart syndrome. So how it will look from point of sonography. So from point of sonography, what you can see, and this is pattern that I'm talking, on grayscale and color power Doppler. On grayscale, you will see small left ventricle. Practically, you will not see small left ventricle. It will be rotation of the heart. So the heart in the hypoplastic left heart is rotated, practically is lying in the across the chest. Yeah. So by color Doppler, you will see just one ventricle filling. Left outflow tract is not detectable. Sometimes, if it's critical aortic stenosis, practically it is practically hypoplastic left heart, but it's still there is flow. So you will see a lasing of the flow with high velocity of the aortic stenosis. Right outflow tract, you will see big, thick pulmonary artery, and you will be not able to see real V sign. And if you're looking for the arch, you will not see the arch, but by doing Doppler, you will see retrograde flow. And let's show you how it looks. So it looks like this. This is normal cases and this abnormal pattern. Yeah. So this abnormal pattern from the abnormal case. Yeah. So you can see filling just one line. So one line of filling, and usually this line is thick. After you can see this pulmonary artery that is coming like banana, like boomerang, with a little bit curve to the aorta. And if you're going higher, you will see this small red area that shows the retrograde flow. So if the baby lying, and we are talking about a situation that baby lies like this, yeah? So if the baby is lying opposite, so contrary to Simon, I'm not turning the position of the waves. I'm scanning transvaginal, transabdominal, I'm scanning this way, yeah? So with transducer down. And in this situation, so the colors will be different. So for this, you will have if the baby is lying back up, you will have blue feeling and red aorta, sorry, red pulmonary artery and blue aorta. So this is case from screening that the doctor performed for very difficult patient. I scanned this patient after, actually I scanned her 3 pregnancies. So this is the first time I scanned her 20 weeks in this pregnancy that I'm showing. And after I scanned her two children, and she was really difficult. So the doctor was able to measure CRL. The doctor was able somehow to measure nucleotranslucency, which I agree that was normal because, okay, it's really difficult. A doctor was able to do ductus and to get tricuspid regurg, and actually everything that it was on scan was good. But after, doctor was not able to get the views that were in our protocol, and that our protocol, as I told, is the same protocol as FMF. So you're supposed to have feeling of the ventricles and V sign. So it was not able to get V sign. So practically speaking, this lady was taken because they have many scanning rooms. They have different machines, different old, new. She was taken few rooms, and they tried to scan in few rooms, and actually they were not able to get the sign. And after it was discussed with they discussed with one of the managers, and they manager told no, it's normal. So it's because she is big. So she was discharged, and she came back at 20 weeks as a normal scan. And at 20 weeks, you can see typical hypoplastic left heart. So there is just one ventricle visible and one ventricle feeling. And you can see that the quality of image is really bad because quality of image is very low. And this is the views of the arch. So this is ductal arch, and this is red coming up. It is exactly retrograde flow in the aortic arch. And if you will, I will stop this image. So 1 sec. So you can see that this image exactly like this image. The only different that it's from different angle of scanning, yeah. And actually, this was not technical problem. And from point of management, it was just mistake of connection of the, instead of trying to send her for additional scan. And understandably at this stage, if you will refer for me, I will do transvaginal scan to see the heart. So ORI scan in 7-14 days. Or she was not referred, and she was scanned just at 20 weeks. So in principle, it's not, it is acceptable because in many units, this is an acceptable situation. But practically speaking, it was possible to prevent her late termination because she terminated this pregnancy after a diagnosis of hypoplastic left heart. So I have clip. Simon was talking about my clips on YouTube. So I have a clip from 2012 regarding hypoplastic left heart syndrome. So you can watch this clip. But actually, I will show you. This is from the same clip. As you can see, this is a baby with significant skin edema. This baby with Turner syndrome, because Turner syndrome strongly associated with hypoplastic left heart, especially if you're talking about hydropic type of Turner syndrome. And you can see exactly what I'm talking. So you can see the coming back, sorry. You can see the feeling of just one ventricle. You can see that left outflow tract is not visible. You can see that right outflow tract, there is single vessel, and this is red vessel here because baby is lying with spine up. And you can see that at the end, there is blue sign here. is because the blood is coming retrograde to the aortic arch. So this is Turner syndrome with apoplastic left heart. And usually in this situation, a lady will choose termination of the pregnancy, but not in all the cases. There is another case, so it's interesting because another case, 11 weeks. So there is suspicion for apoplastic left heart because there is just one ventricle filling. But from other point of view, you can't, I was not able to see the reverse flow in the aortic arch, so it was not confirmed. Interesting that with apoplastic left heart, there is no TR. So if somebody is using TR as a marker for heart abnormalities, so for apoplastic left heart to have TR, it's bad prognostic sign. It is really bad prognostic sign because for normal, not normal, or at least to live, you're supposed to have competent valve. Because if you have one ventricle and this valve is not competent, so how you will have circulation? So practically speaking, in majority of the case, apoplastic left heart, it will be not TR, because again, I'm telling that if you have TR for apoplastic left heart syndrome, it is a bad prognostic sign, and in majority of the case there is no TR. So that's why here I can't see any TR. And baby, she was scanned late. I just want to show this interesting finding because if somebody is doing transvaginal scan, for sure you've seen this finding, and you may think that it's something that it is abnormal, but it is not ascites. It's normal finding. I don't know exactly what type of tissue baby has. So on cross section you can see normal stomach, and you can see this finding close to the rib. Probably this is some lymphatic tissue that actually present absolutely normal variation of development. It will disappear in later stage, and you can see this finding usually when you're doing transvaginal scan with a preset, with high contrast preset. So it's not fluid, it is some tissue, and it will be normal follow-up. So this baby has this tissue, but if you will look for the heart, so what you can see in just 1 week, you can see first that there is mitral atresia, so the mitral valve is not opening. And from other side, you can see that the right ventricle is big. It's forming the apex of the heart. And if you are looking for the colors, so on colors you can see what I was talking before, because on the colors you can see this is pulmonary artery, and this is one ventricle filling. So one ventricle filling, there is no tricuspid regurg. Okay, maybe tiny, not really detectable. And after you can see this thick, very thick artery coming directly from the right ventricle to the descending aorta, and this is a red signal of the reverse flow in the aortic arch. So this is typical apoplastic left heart syndrome as seen on screening. So again, this is not fetal echocardiography, but it's enough actually. If you're asking me if I will show this image for cardiologist at this stage at 12 weeks, so cardiologist will say, okay, I can cancel this lady. I can go and cancel this lady, because cardiologist will tell her, okay, look, the size of the heart at this stage is like this, but your baby has definitely a significant heart abnormality, and the outcome of this abnormality, this is spectrum of outcome of this abnormality. And if you would like to continue your pregnancy, we are very happy to scan you again late and to tell you what are details, if there is restricted flow through foramen ovale or something that will change prognosis. Or if you don't want to continue the pregnancy, you can terminate the pregnancy at this stage, because your baby definitely has significant heart abnormality, and it is ductal dependent abnormality. Why I am telling you that it's ductal dependent abnormality? Because the feeding of the brain of the baby is going through ductus. This is the ductus and this reverse flow in the aortic arch. So this is practically speaking diagnostic, and even you can cancel at this stage, even with all the limitations of your imaging. So this is what the same case. I'm just telling that it was suspected at 11 weeks. At 11 weeks, by the way, we did, because of heart abnormality, we did invasive test, we did CVS. And when she was scanned together with cardiologist, they said 12 weeks. So she had first results of CVS, and after she got normal results, also second part of the results. At that time, it was karyotype, not a race. So this is what I'm talking, and the huge mistake. I was thinking long ago, 10 years ago, more than 10 years ago, I was thinking that this is hypoplastic left heart. Is not. This is not hypoplastic left heart. Don't do this mistake. Refer for cardiologist, and don't tell for mom that this is a disaster because the baby will have an ventricular repair, because it may be not. At the end of the day, it can be just coarctation, and the outcome, general outcome of the baby will be much better comparing to the hypoplastic left heart. So this is just warning for you, but you must refer those cases, because coarctation is also, it is not mistake to refer. I think it's also not mistake if somebody is referring this case. I think it's just a second. It's important to talk about this. So from point of your referrals, I'm talking to people who are not cardiologists, who are obstetricians, gynecologists, sonographers, and people are scanning low risk population. So you're referring patient for cardiologist because you found something. And you're calling this, I don't know, you're calling this transposition of great arteries. And at the end of the day, the cardiologist can see the finding, and they maybe laugh and tell, okay, you refer transposition, but actually this is hypoplastic left heart. Wow. I think it's not mistake that you did. You did absolutely correct thing. You detected abnormality. You have no so big experience like cardiologists. There is no any point of cardiologist to laugh and to tell, okay, person don't know cardiology because actually it's not, doesn't know exactly the name of this condition. You did correct thing. You detected abnormal heart, and you refer this baby for correct pathway for people who know what to do. This is great. This is amazing. So they're not diagnosis is important. The important is pathway, how you are doing. Opposite situation, you are scanning the baby and you can detect hypoplastic left heart, but actually you have no any connection to cardiologist. So you're telling, okay, you know what, I think the hypoplastic left heart is very bad. So she's asking what to do. And you are telling, okay, this is my report. You can do if you want to do termination because wow, it's not good. So do termination and go somewhere and find cardiologist to treat you. And she's coming to the cardiologist with your report, and because cardiologist is not is not connected to you, is telling, okay, somebody scan your heart, you know, at 12 weeks, and thinking about hypoplastic left heart, but it's not possible to detect it at 11 weeks or 12 weeks hypoplastic left heart. So I will not scan. I will scan at 20 weeks, and let's see at 20 weeks. So this is bad situation. So it's you. We need to create pathways of referrals and to understand what to do with some findings. That's why yesterday I was talking that if you want to scan the hearts, first of all, think what you will do with abnormal finding. If you can't do anything with abnormal finding, have two ways: not to scan at all and forget about this and to be driver or taxi or whatever, or to try to convince people working with you that actually it is possible to detect those abnormalities, and actually they can also detect this and they can also scan, and actually we can work together. So this is the most important thing. So coming back to the lecture. So this is another case that, yeah, this baby has also Turner syndrome. It's hydropic, it has pleural infusion, and it has very bad position because I'm doing transvaginal scan. And on transvaginal scan, I can see in septal view, practically speaking, two ventricles. I can see left and right ventricle. So this is disproportion. Yes, this baby is supposed to be followed up because it can develop hypoplastic left heart, but at this moment, it's not hypoplastic left heart. So you are turning transducer and you can be surprised that actually you are able to see flow through the chamber that you're thinking that it is absent. And in this situation, of course, it's quite difficult to tell if there is flow through the valve. And I think it's flow through the valve because you can see the valve, the mitral valve opening here on 2D. Even that this is not good image. I'm especially giving you not the best images and old images because I want you to understand that it was possible to detect many, many years ago this. So this is opening of the mitral valve and this is closing of the mitral valve. So this mitral valve is patent and there is some flow from mitral valve. So this is not hypoplastic left heart syndrome, but this baby is supposed to be followed up by cardiologist. So you will refer this baby for cardiologist and cardiologist supposed to confirm that there is disproportion to follow up this case in question if this baby has coarctation of the aorta. Or it can be not coarctation of the aorta, it can be aortic stenosis and baby can develop eventually hypoplastic left heart syndrome. So this is critical aortic stenosis and this critical aortic stenosis, so there is still, as I showed you, filling of the left ventricle, but you can see that there is a reverse flow in the aortic arch. And in this situation, it means that it's already a ductal dependent lesion. And this baby have chances that it will develop hypoplastic left heart in the future. And this is how this baby was looking because it has Turner syndrome, cystic hygroma, and all those conditions. So this is other interesting case because, yeah, Turner syndrome again, cystic hygroma, 13 weeks, transabdominal scan, severe edema, pleural infusions. But for us, it's interesting to see the heart. So looking on the heart, you can see for chamber view, and you can see this echogenic finding. So you can see here echogenic finding on the side that here this is the echogenic finding, and it's on the sitting on the septum, and this septum, if you will look better, and I have better clips. First of all, what I would like to show that this is not echogenic foci. So echogenic foci is something that is connected to papillary muscles. And you can see it bright in the part. We did a lot of amniocentesis about 25 years ago for these findings. Many ladies, they got amniocentesis for these findings. Now we even not mention this during scan of the hearts. In the past, we have those cases that somebody was following up for echogenic foci, and after baby was delivering with severe heart abnormalities because a part of this echogenic break thing, the person was not able to recognize anything in the heart. So it was very important findings 25 years ago. Now is nothing. But this finding is important because this finding probably represents the atretic left outflow tract. And it also may be part of the fibroelastosis. So this stage is uncommon to have fibroelastosis of the left ventricle, but it can be beginning of development of fibroelastosis. And the important thing that when you are scanning to see that there is no contraction of the left ventricle. So practically speaking, even that you can get somehow the image of four-chamber view. So you have right atrium, right ventricle, left ventricle, and left ventricle atrium. But practically speaking, it's already a univentricular heart. And how I can confirm this? I can confirm this by doing Dopplers. So by doing Dopplers, I can get all the picture of the hypoplastic left heart. So feeling of the just right ventricle, pulmonary artery. In this case, it is red, and the aortic arch that come in a different way. So, and this is hypoplastic left heart. Again, Turner syndrome baby. Why Turner syndrome baby? I have so many Turner syndrome baby because, as I told, I'm scanning all babies with increased nuchal, and hydropic forms of Turner syndrome will have increased nuchal. So I've seen many. So it's interesting in some cases. This is technical point, and it's be careful because I even knowing what I will show you now, I made by myself mistakes. So because in this case you can see practically normal looking V sign, yeah. So you're doing scan. This is linear probe, so high frequency linear probe, and on this linear probe I'm getting very nice red V sign, and I may be happy. So because if the aorta is coming this way and pulmonary artery and ductus coming this way, so it means that practically speaking, so this is not hypoplastic left heart per definition. So there are two possibilities here. First possibility that actually this is a double outlet right ventricle, and two arteries are connected to the single ventricle that it is right. Left ventricle is atretic, so there is no left ventricle. Practically speaking, it is the outcome also will be bad because it will be univentricular repair. So it will be not biventricular repair. But second situation in this, it is just because of position. So what happens that I'm scanning this way that the pulmonary artery and ductus is coming forward, and aorta is actually angulated in different angle, and that's why the reverse flow in the aorta actually in this case will be red, because the ductus coming this way and the aorta coming this way. So the blood coming this, so you're just not understanding this. To avoid this mistake, you're turning transducer in positions that both arteries are coming the same direction. And you can see this is blue retrograde flow, 1 sec. So this is red, and here will be blue. Yeah. So this finding confirms that the baby has hypoplastic left heart. So again, this one more case. You can see here presence some kind of four-chamber view, but if you will be very carefully looking for the valve, you will see that the valve is not opening. The valve is not opening, and if the valve is not opening, so it is atretic. So, and this finding confirms color Doppler. So hypoplastic left heart type of abnormalities is very important to see by Doppler. And Simon was talking quite a lot about doing sagittal view. So you are doing sagittal view, and in sagittal view you are getting the arcs, and it's good view. I like it, but I think from diagnostic point of view, there are just few situations that you need to perform this kind of view, and I don't think that we need to scan normal baby and to get for every baby this view of the arch. This view is supposed to be reserved for the situations that the arch can be abnormal, and and this is exactly the situation. So you are doing in axial view, you're getting this reverse flow, and you're rotating your transducer 90 degrees, and you can confirm this finding by this, and exactly the same you can do it second trimester. So you are looking for the arch. You may think that it is aortic arch, but practically speaking, this is ductal arch. So it's coming from the close to the chest, from the right ventricle, going down in quite right angle, and this is reverse flow in the aortic arch. So this is confirmation. Yes, you can do stick I told, I have no time to do sticks. I have no time to do many things that can produce nice imaging, if you're asking me, because we have limitation. We have a lot of cases, limitation time to scan, because there is next case to come. So from point of scanning, what I think we need to have approach that it's pragmatic approach. What does it mean? You can see the pattern, you know, definitely that this is this type of abnormality. So you don't need to get all possible beautiful views, improvement of quality of the image. Yes, it's very important, but actually the important thing is not to all this imaging, is what to do after with case. And I've seen one cardiologist that one of the top level cardiologists that is scanning from my point of view at absolutely not presetted machine with a lot of artifacts, but a cardiologist was able to, from this image, to get absolutely correct diagnosis and to give absolutely correct way of pathway of treatment and good counseling. So the important thing is not just the image. I agree that I like beautiful images. I really like them. But the important thing actually the pathway, what to do, what kind of counseling to give. And so that's why I'm really not spending now time for doing sticks in the cases that that baby is not in good position, jumping, because the important thing is finding that this baby has apoplastic left heart. So, and again, so you can do clear stick, you can color the image, and but at the end of the day, the important thing is management. Interesting thing that I'm collecting because I'm not interested really in the PI of ductus venosus in first semester. So I think it's not helpful at all. And I'm collecting cases of serious heart abnormalities that have absolutely normal cardiac markers. And this is one of the cases because the baby has apoplastic left heart and has normal karyotype, of course, and has normal nucleotranslucent. It's difficult to measure because the baby is extended in this position, and completely normal ductus venosus. So conclusions regarding apoplastic left heart, majority of the apoplastic left heart cases are detectable and predictable at 11, 13 weeks on 4-chamber view. And now we have confirmation that actually it's more than 90%. Every case of right to left disproportion, ventricular disproportion needs to be rescanned in 10, 14 days. It's very important. If you have any cardiac findings, not just cardiac findings. Okay, if the baby has no arm, so you can rescan later because it has no arm, definitely. But the structures that developing, the time of, if you find something wrong, the time of scanning again, actually it's very short because the development of the baby is going very, very fast. So for the heart with the disproportion of the ventricles, I think 2 weeks is the time to scan again to see what's going on. With the brain first semester, the same. 2 weeks, 10 days to check again what's going on. So if we are talking about cases of disproportion, so some of the cases they will go to direction of the coarctation of the aorta, majority. Some of the cases, if it's mild disproportion, will be normal. Some of the cases can develop eventually apoplastic left heart syndrome because they are associated with the critical aortic stenosis. Apoplastic left heart can be associated with increased nucleotranslucency, and the most common chromosomal finding will be Turner syndrome. So I recommend to do invasive test for apoplastic left heart because it can be Turner syndrome. And additional thing that if you are scanning baby and the baby has the features that you think that apoplastic left heart, but the report from cardiologist is coming back as VSD and, for instance, double outlet right ventricle. So be happy that you referred correct case to cardiologist, and not to be unhappy that you did different, not correct diagnosis, because you did right. You found the problem and you referred for correct pathway. Coarctation of the aorta. So coarctation of the aorta is tricky. So coarctation of the aorta is tricky, and we have many cases that, again, what I'm telling you, it's not statistic, it's the cases that because I'm scanning those ladies at 12 weeks next pregnancy, so I can hear the stories of diagnosed, late diagnosed, or misdiagnosed for many conditions. So I've seen quite many ladies that they had undiagnosed coarctations of the aorta, and it's completely understandable because it's difficult for even for cardiologists to be sure that this is coarctation. So from point of pattern that you can see on screening, on grayscale, you can see sometimes disproportion. Sometimes it's not visible disproportion, but I'm completely sure that the important way to see disproportion is to see the different ventricular filling. And for coarctation of the aorta, the strip of filling of the left ventricle may be shorter. I'm not talking that for every coarctation, but it will be shorter than the right ventricle. And be careful of this finding, because if the heart is pointing, so if the heart is pointing up as I wish, with a 45 degrees up, it is, and you have to see this proportion. So this is good position, but you need to see in every frame this proportion. But if the heart is pointing down like this and the left ventricle is here, it can be a technical disproportion. Because of technical reasons, the right ventricle can be bigger, can seem bigger than the left ventricle. I don't know why. Maybe because it's close to the surface. Maybe because it's less shadowed by rib. But if the pointing, the heart pointing down, be careful with this proportion. If the heart is pointing, as we were talking yesterday, 11 o'clock, so this is disproportion. So left outflow tract in both cases will be normal. So it's because by color, color actually, if the baby can have coarctation, color can mislead you. I have no time to talk about this, but colors in the case of coarctation, I think supposed to be used very careful, because the wideness of the vessel by color is wider than the vessel itself. So it can create image that actually the size of the vessel is bigger than that you're thinking. And if you're going to the up, so the pulmonary artery will be higher, that bigger than the aorta, sorry, in both colors and 2D. And in the case that you are looking for vessels coming in this view, so you can see the thickness of the vessel, and it's easy to do this. So you can see sometimes really narrow aorta, but this is not coarctation. It will be apoplasia of the aorta, because coarctation is discrete narrowing of the vessel, not narrowing of all aortic arch. So how it will look? It will look that this is normal heart, this is abnormal heart. So, and this is the diastole and this is systole. So it's clear that the red filling will be during diastole. It's systole of the atrium. And on the systole, you will see this crossing and V sign, yeah? So in the case of coarctation, you will see shorter left ventricle, and you will see smaller aortic arch. But again, on color aortic arch, be careful with this smallness, because not everybody can produce images like Simon producing. So be careful, because Simon is able to produce this kind of imaging. And sorry, I forgotten to show the slide. Yeah, sorry. So I forgotten to show the slide. Yeah. It's good that I have team that helping here. That sorry. So what I'm showing here on this diagram, that on a diastole, you can see that the strip of the left ventricle is shorter than the right ventricle. And this is a feature that is seen on colors better than without colors. So practically speaking, you can see this just on colors, and aorta will be smaller. So again, we have clip from 2012 of quotation of the aorta that we have no time to show this. You can see on YouTube. And this is the cases that how it looks. So it looks, sometimes it's visible on 2D. So on 2D here is showing that actually have disproportion of the ventricles. 1 second, it will run again. So you can see visible disproportion of the ventricles. So the left ventricle is smaller. And you can see also this feature on transabdominal and transvaginal image. And by once again, I'm going back, and on image, transabdominal image, you can see even disproportion between size of the arteries. Again, this is clip from Volison 730, so it's very old clip. And still, even on this old machine, you were able transabdominal to see those features. So this is a big pulmonary artery and duct, relatively small aorta, because the aorta is the size of superior vena cava. So this is suspicious for coarctation. And when you are doing the scan, so you can see that this feature that I'm calling Traus's sign, and I showed you yesterday this image, that actually there is feeling of the ventricle that they're coming very close like this. So, and if you can see this, it is suspicious for septal defect. It can be ventricular septal defect or AVSD. So, and this baby had at the end, it had VSD, and it has coarctation. Coarctation in about 40% of cases associated with the VSD. So, and this is important to know. And the coarctation progressed, and when she was scanned by cardiac team later, so this scan, I think it's about 13 weeks. So in more than 2 weeks later, they were thinking that maybe it is interrupted aortic arch. So because it was so severe coarctation, they were not sure that it is coarctation or interrupted arch. So this is another case. This is interesting because when you're looking for 2D, it looks completely normal. It looks for me, if you somebody will ask me what I think about this heart, I will tell, okay, normal heart, feel well, send this lady home, and scan again at 20 weeks because it's normal for chamber view. If you think that the right ventricle is bigger, that because of shape of our right ventricle, because the right ventricle is a little bit thicker and a little bit shorter, so you can see here aorta forming the apex, so normal heart. But when you will look on colors, this is it's amazing because actually it is very subtle. But you can see here disproportion. This is consistent disproportion. So there's consistent. It's old clip. So you have this disproportion. There's some tricuspid regurg, but in all frames of this this heart, the left ventricle is less small, and this the size of left ventricle is smaller than the right ventricle. So what to do in this case? Of course, you can't tell that it is coarctation. Of course, you can't tell for parents that something wrong, but I think you need to find the reason to rescan this baby again. So because it is important finding. And to rescan again, it depends on which stage you would like to rescan, but I recommend to see again in 2 weeks. And if it's getting better, to scan again at 20 weeks. So, and at the end of the day, this was coarctation of the aorta with the surgery after delivery. So it is very subtle subtle finding. So next case is different because this is obvious. Oops, sorry. This is obvious because here, if we'll come from this is the clip is from 2009. So you are looking from lower part. So you're going. This is the arch, and here you can see feeling of the ventricles. So this is right ventricle. So the spine is here. So the right ventricle. This is left ventricle. Right ventricle has significant tricuspid arch. There is disproportion on all those images. After it, you can see really big pulmonary artery. So you may think that it is apoplastic left heart, but it's not apoplastic left heart because it's filling of the left ventricle. And this is narrow aorta. So flowing aorta is not visible because of position of the aorta that it's horizontal to the transducer. So the flow in this part of the vessel is zero. And one more baby long ago. Again, this baby has, so this is, it has this disproportion between the aorta, and actually it has also ARSA. So this is, but ARSA is not the marker for cortation of the aorta. So in the isolated ARSA, we actually probably has no big significant clinical value. So, and this baby has cortation, but in context of Turner syndrome. So this is another case that you are scanning, you can see that huge cystic hygroma. You can do 3D for measurements of nucleotranslucency. I think the number of measurements here is completely useless because you can see, if you can see this here, cystic hygroma, so your measurement has no any prognostic value, anything. So yes, you need to measure something, but from point of management, what you need to do is to check the heart. And when you're checking the heart, you're getting this information. So you're getting, again, the image of the heart from different angles, that there's this proportion between two chambers, small left ventricle, and here you can see, it looks like the aortic arch, yeah? So, and the same, you can see the baby from the back of the baby. And again, you can see here the findings practically the same like I showed you before. So this is aortic arch hypoplasia and severe tricuspid regurg. So this case is very similar to other case. And this is the image of taken by stick, which you may tell me, okay, Fred, this is the same baby. No, this is not the same baby. It is the same stick, not in the same stick. It's a different stick. Again, it's coming back to 10 years ago. And what was plus in stick that you were able at that time to reduce the velocity of the image, so you can make slow and you can get better information. But practically speaking, now you can do the same with clips, because I don't think that old Wollasons gave this possibility that you are just reducing the velocity of the clip, but now you can do this, or you can just scroll and to get all the information. So right ventricular disproportion, 13 weeks, different case. Again, so nothing, it looks everything is good. So the lady, this is amazing case, yeah. The lady was has this disproportion, and after actually all the views were normal, and she had scanned by cardiologist, by very experienced cardiologist at 19 week, which was completely normal. So cardiologist was completely convinced that it's normal heart, on the level that decided not to rebook for rescanning, because many times cardiologists, and they have experience, so they are rebooking in 8 weeks. So in this case, very experienced cardiologist decided not to do this because he was convinced. And the ductus venosus at first trimester was completely reassuring. Baby was born, sent home, and collapsed a few days after delivery because of coarctation of the aorta. So this is important thing. So be very careful with minor, even disproportion and minor smallness of the left ventricle. But be careful. I'm not telling that you need to refer all those patients for cardiologists. I just think that you're supposed to rescan in 2 weeks to see that if it's going worse or less, and after to be careful, scan at 20 weeks, thinking about possibility that this baby can have coarctation. If you are not sure at 20 weeks, you can refer for cardiologist, because if you're waiting for 20 weeks in those cases, subtle cases, so practically speaking, you are not delaying the diagnosis, yeah? Because what for important for the baby is if it's coarctation, so to be treated after delivery, not before. I agree that some coarctations can be associated with chromosomal problems. Yes, but usually in those coarctations, they have multiple problems, not just a single coarctation. So conclusions, if you have disproportionate right ventricle, left ventricle, or even they are on the same level, so rescan, as I told before, so let's go further. AVSD. AVSD is something that if it's big, so you may see this, and we can see experience of Fetal Medicine Foundation that more than 90% was detected, and they detected AVSDs not associated with Down syndrome. So actually, the probably majority of the babies, they have abnormalities of the heart, not some markers that the increased chances for chromosomal issues. So AVSD is not just hole in septum or atrial septum and ventricular septum. It's major abnormality of the middle of the formation of the heart with common AV valve. And this is very helpful for us for make diagnose. So our last conference, we invited Professor Bronstein. He was talking about absolutely amazing lecture about detection, his experience of detection AVSDs by transvaginal scan at 15 weeks. And he was able to show really difficult for diagnose cases of AVSD. But in majority of the cases, AVSD that we can detect at this stage of pregnancy, I'm talking about 12, 13 weeks by screening. Those not the cases that Professor Bronstein was talking. The case that he was talking, these cases for echocardiography. It's cases that Simon Marr can find, but not they will be not visible on the screening scan. But the good thing that majority of the AVSDs that we can detect, actually they are visible because they're big, not very, very small or difficult for detection AVSDs. So from point of sonographic pattern on grayscale, actually they are really visible because there is no cracks. There is no cracks, and what I think it looks like there is 2 doors opening wide, and you can see this if AVSD is big. So, and I call this trousers. So because it looks like trousers by color Doppler. So you can see the absence of cracks on normal 2D scan. And the trousers that you will see on color Doppler, I will show you what does it mean. And everything else can be normal. So this is important. So this AVSD, contrary to many other conditions that actually we will see because of abnormality of the V sign. So V sign is abnormal in many conditions, but not on AVSD. So AVSD can have some disproportion, and usually is narrow aorta, but in majority of the cases, it will have normal V sign. So if you are looking just for V sign, it means that you can miss or single ventricle, if you're not looking for the heart, for the feeling of the heart, for chamber view, or AVSD. So, and how it looks like this kind of V sign which I think it's the correct name is Strauss. I will show you why. And it can be also on systole that you can see elazing in the middle of the heart. So elazing in the middle of the heart, it is regurgitation. And in the case of AVSD, it's not tricuspid valve. So it's funny because I've seen many referrals that AVSD, tricuspid regurgitation. So there is no tricuspid valve. So it can't be tricuspid regurgitation. It's regurgitation of the common AVL valve. So this clip is old, but this was situation about 10 years ago that actually a lady in London was able to have many scans and were referred for the unit, for fetal medicine unit because of some findings, which is extracardiac. And you can get this image as a first image that you are checking heartbeat. So, and of course, this baby has very, very high chance to have undiagnosed Down syndrome. But this time actually is over. And after implementation of the protocol for second trimester, after training of the sonographers, it's practically speaking, it's uncommon to see this situation. It can happen if the baby, not baby, is the mother is really big, but it's uncommon finding now. So, but 10 years ago, it was quite common. So this is clip that you have on YouTube, so you can find it. And this is the how it looks. Again, this is old machines. So on new machines, you can see it much better. By purpose, I'm not showing you new clips. And for new clips will be next week, because next week I'm supposed to talk about all anomalies that I think are detectable in first semester. And so I'll show you the new, the resolution of not all the cases, because some of the cases are still old. And but you will see the resolution for new. And this is how you can get for transabdominal scan. So practically speaking, you can see this. And for this, you don't need to have high frequency transducer. So it's easy visible by using completely regular transducer, like this. Sorry. And this is typical because this baby has trisomy 21. Sorry. So it has regurgitation that somebody called tricuspid, but it was regurgitation of common valve. It has reverse ductus venosus wave, A wave, because of Down syndrome, and it has also ARSA. I hope that's visible. But again, ARSA in this situation, it is minor finding comparing to this big problem in the middle of the heart. So different case, the baby, as you can see, baby is hydropic. The type of hydrops is different from cystic hygroma. So this is not really, even that there is two unusual cysts. So hydropic baby, of course, this baby will need to have invasive test. But scanning of the heart, you can see this image, which is like this. Yeah, so it's filling from single orifice, and after it's divided into because the colors are not really good presetted in all times, so I can't. It looks like just filling of the one cavity, but on 2D you can see that this is common valve and the receptor. So trisomy 21, common AV valve regurg, as seen blue. This is important. I can forget to mention you, but tricuspid regurg many times was interfering with my ability to see to define heart abnormalities, because not in this case it's not tricuspid, it is common AV valve regurgitation, but this regurgitation is coincidentally to the flow through the aorta, and many times you're not sure that it is it regurgitation or it is overriding of the aorta on the color image, that you still have no possibility to see the valve itself. So, and this is a stick again, transabdominal stick. You can see there is some some disproportions between quite small aorta and big pulmonary artery. And some AVSDs, and this is small AVSD that it's difficult for detect. So this AVSD actually the AVSD that you can get cracks. So in this AVSD, you can get cracks, and I will show you. And even offsetting of the valve here. So it looks like offsetting of the valve, and it looks like baby has cracks. And the image of the heart, there is no tricuspid, no, sorry, again, I'm talking tricuspid, there is no AV valve regurg, but you can see this unusual feeling. So you can see this feeling, trousers type feeling here. So the feeling is going like this. So, and so be careful. So this baby has Down syndrome. The mom decided to continue the pregnancy, and at the end of the day, the baby has had a VSD. And if you're asking me if it was easy to detect this, it was not easy. It was difficult, and maybe at that time, if I had no idea that if I don't know that this baby has Down syndrome, because when I scanned, I already knew that it's Down syndrome baby. Maybe I was thinking that the heart is normal and passed this case as normal. So, and there is no regurg. So I tried to see a common valve regurg. There was nothing. So absence of regurg doesn't exclude a VSD, and this is trousers sign. So the trousers, there are red trousers. This is red trousers when the baby is lying in position that facing up, and blue trousers if it's facing down. So contrary to Simon, I'm not changing. I told you yesterday that I'm not changing the direction of the colors, because if I know that baby facing down, like at 20 weeks, if the baby is facing down, you never change the colors, isn't it? So the same, I'm not changing colors. I'm not changing the position of the clip, because I just know, okay, this is red because this flow, the flow is forward, and blue is because it's going a different way. So this case, it's really old. So this lady, I will show you just. So this is common AV valve. The lady asked, when I scanned again, I knew that this baby already has Down syndrome. And she came asking if the baby had problem or not. We scanned her with cardiologist and confirmed AVSD. But what is interesting, that this clip, Voluson 730, 2010, transvaginal scan. After she came back next pregnancy, Voluson 730 transvaginal scan, normal heart, delivered normal baby. And after she came back with new pregnancy, I scanned Voluson E8, transabdominal scan just, because it was kind of screening scan. So if you have problems or not, and actually this baby already, so at this stage, I have enough experience to think that if you can get this image of filling to ventricles, separate filling, and those outflow tracts, that you don't need to run, in this case, to do transvaginal scan, because this is screening. So this is not echocardiography. We'll not do echocardiography for everything. A part of, because she's coming for screening scan, even that there is, she has previous history, but if the findings of screening scan is normal, so next scan we'll do echocardiography at 20 weeks. And at 20 weeks, the heart was normal, so I haven't performed transvaginal scan. So combined screening at 11 weeks, 6 days, negative cardiac markers, so everything is normal. And you can see red trousers, one of the image that it's not my imaging, so my images are red trousers here, a normal outflow tract. So the person who is doing the scan on old Wollaston 10 years ago, we were able technically to get this image of red trousers and referred for us and scanned the same day, 11 plus 6 AVSD, transvaginal AVSD, scanned with those images, just a second. Color Doppler, there is regard. And by blind technique that previously was scanned in other units same day, actually they were not able to get any regurgitation, but it's clear if you're putting colors exactly sample volume of the regard, you can see regard, but missed here. And actually she was canceled same day because we were coming, cardiologists are coming for us once per week. So she was fortunate that a cardiologist, it was day of cardiology. So she was canceled by cardiologist the same day at 11 weeks, 6 days. That cardiologist warned her that it is tentative diagnosis, that it's still early pregnancy. So recommendation to do CVS and to rescan after CVF is normal. But actually, she terminated of the pregnancy without any additional checking. And this is another case that the case was confirmed. So actually, the concern, as you understand, if you have these findings, that you need to do invasive test. Okay, and this is a scan resolution from the same case. That this is transabdominal 13 weeks. Again, old clips, without any slow flow, radiant flow, without all this, just scan. And this is 11 weeks plus 6 days. So you can see that practically speaking, from point of resolution, 11 weeks transvaginal, close to 13 weeks transabdominal. So practically speaking, it's not enough to do transabdominal scan at 11 weeks. You need to do transvaginal. So in 13 weeks is 2 weeks different between transvaginal and transabdominal scan and resolution of the hearts. So let's go further. Conclusions regarding AVSD. So it's common. It is visible in 4-chamber view. Severe cases are detectable at 11, 13 weeks. Need to be differentiated from univentricular hearts is very important because big AVSD can have normal repair, and this is AVSD of the baby that has Down syndrome. So this is Down syndrome girl that she has a AVSD, and I seen her, the girl, 3 years of age. So she had Down syndrome, but from point of cardiac repair, she had complete normal repair of the heart with biventricular repair of the heart. So those huge hugely abnormal hearts can be repaired by cardiologists in many places of the world, and with good outcome. Of course, you can't repair this stage Down syndrome. So, and if you're talking about cases that I think for today I will stop because I have also questions. Because I have 2 lectures that are the same as lecture for Simon. Because 2 other cases not cases, 2 other anomalies that I supposed to discuss are transposition of great arteries, and Simon gave fantastic lecture, and I will come back again in next Saturday about transposition to show you cases of transposition on screening. And so it's big part of transposition. And the same I'm talking about just a second. So I'm talking about tetralogy of Fallot pattern. So tetralogy of Fallot has also pattern that Simon described. My views, by the way, on tetralogy of Fallot are a little bit different because I think it is can easily detect it at 12 weeks tetralogy follow. I'm not talking about very mild cases of the pulmonary artery practically is not atretic. Sorry, not apoplastic, but in majority of the cases, the problem of tetralogy follow not to find it. The problem is actually to tell that it's tetralogy follow, not tricuspid, sorry, not pulmonary atresia, not double outlet. So this is the problem, because you can see single vessel coming from the middle of the heart. You can see this kind of overriding. You can see abnormal curve of the aortic arch, and actually you can't see pulmonary artery. And in those cases, it's difficult to cancel, because actually canceling based on presence of this pulmonary artery, and from there it's coming. So this is the important thing, and but from point of pattern, they're really visible, and I will show you next Saturday. So coming back to what I'm trying to talk is that this is the results of the outcome of scanning of the Fetal Medicine Foundation for a long period of time. And as you can see, they were able to detect 40% of tetralogy follow, which is amazing. It's very good. We're talking about first trimester transabdominal scan. They miss majority of transposition of great arteries, and that's why we will talk again about transposition of great arteries. I will show you cases how people are missing transposition of great arteries and why they're missing transposition of great arteries. But it's important, because transposition of the great arteries, if you are missing at 12 weeks, it's okay, everybody can understand this. But the baby has 50% chance missed again, because in majority of the countries, the detection rate is about 50%. So if it missed twice, so there's chance that the baby will be delivered and in not controllable situation, and it's very, very dangerous. So simple algorithm for heart examination. So you're looking for the heart, very simple. Clip 6-second transabdominal without color, without slow flow, without 3D, 4D, 5D, whatever, just simple scan, very short. And my understanding that the shock will support this type of scan. And you're asking just for 5 questions. If it's hypoplastic left heart, no. Is it AVSD, big AVSD, no. If it's transposition of great arteries, no. If it's tetralogy follow, no. If it's coarctation, I don't know, probably not. So if the baby has everything is normal, so you can exclude statistically 80% of heart abnormalities. So if you're asking me, I think that on screening, the number of detection of heart abnormalities, it's close to 80%, because other abnormalities, you will see that something major abnormal. Because here it's not, I'm not talking about univentricular heart, you're supposed to see univentricular heart. If the heart is out of the chest, you're supposed to see this, of course. If there is not hypoplastic left heart, here, sorry, it's missing L. So if it's not hypoplastic left heart, so it can be hypoplastic right heart. So there are a lot of conditions that you will detect just by using this simple algorithm. So thank you. I'm very sorry for yesterday for technical issues. As you can see, actually we improved our performance and have a much better performance today. We have small technical issues today that we will improve again. The lectures from yesterday, I will re-record, but it will take a few days because I think I'm very sorry, and I think if somebody wants to see record, the person supposed to see a good quality of record and not what we did yesterday. But yesterday, all the settings, we have all these settings, but something doesn't work, and I'm really sorry for this. So there are some questions that I would like to answer. This is the question for, I hope that it's for me, because I don't know what Simon will answer, but how many time need for the examination? Heart examination only. So for screening examination of the heart, you need less than 1 minute, because if the baby is lying in position, as I told, you measure nuchal, yeah? If you can measure nuchal, there is no any explanation why you can't scan the heart. Or maybe you can measure the nuchal. This is different, and you are measuring something. But if you measured nuchal, sorry, something happens, so I'm sorry. Okay. Uh, I hope they can hear me. I think I touched the panel of questions and answers. Sorry. So do we need to measure the ratio between right ventricle and left ventricle for reference? Yes, there is ratio. We actually we have a presentation in Singapore. If you'll check Singapore, there is a ratio that we developed for the length of the ventricles, and we are writing paper just now about this ratio. So yes, so if you measure both, there is ratio, and if the ventricles are the same size, so it is borderline. If the left ventricle is longer, that right ventricle is okay. If right ventricle is longer, it is not okay, and we're writing paper for this. But it's visible, so you can measure, but actually, practically speaking, is visible without any measurement. Is it possible to use okay, so this is I can't. More visible pointer. I'm using usual pointer, so maybe next time I will try to use bigger arrow. So sorry. Yeah, I can see what you are talking about. Sorry that I've seen it just now. Will sagittal view of the aorta help in diagnosis of coarctation? Oh, fantastic. So sagittal view of aorta, of course, will help diagnose of coarctation in the second and third trimester. In the first trimester, you need to be Simon Marr to get this image. And the problem that if you will do sagittal view of the aorta, actually, the problem that you will get the resolution. So you can do this just with colors. Without colors, it will be not visible. And without colors, on resolution of any machine, I believe at least machine that I used, the lateral resolution will be not good. Lateral resolution is 4 times less than resolution of the axial. So and in this situation, in axial views, you will see the narrow vessel. But if the vessel is going like this, you can use just colors. When you are using colors, the color will make the vessel wider. So, and second, I don't think that this is really from all the anomalies, coarctation of the aorta, this diagnosis supposed to be confirmed by cardiologists, and cardiologists supposed to follow up the cases. So you just, if you think that it's coarctation, so please refer for cardiologists. And I don't think that cardiologists, in majority of the cases, a part of the cases that it is really hypoplastic aortic arch. will make will will make diagnosis at this stage. Usually what they are telling that, okay, we can't exclude coarctation, so let's rescan, let's rescan, let's rescan. And the most important that what they will tell after birth, because after birth, there are two situations. If they are sure that it's coarctation, so they need to give prostin. But in many cases, they're not giving prostin. They are just asking for a scan immediately after birth. So after birth, the baby can be rescanned, and if there is coarctation, and as you understand, after birth, it may be easy to see the narrowing of the aortic arch, again by experienced team. And if they can see this narrowing of the discrete narrowing of the aortic arch, so they will start prostin to prevent closure of the ductus, because coarctation is ductal dependent finding. So I think that it's enough for today. And I really enjoyed presentation of Simon Marr. I enjoyed the presentation of Peter, because Peter gave very good overview about new technologies. Because what I'm showing that screen, but the new technologies actually will give us possibility to do real e-echo, early echo, quite soon. Because if we will get these machines, and especially if transabdominal scanning will be improved, so more cardiologists will be able to scan early hearts, and we will make this connection between our screening and cardiology. So our next day will be 19th Saturday, and it will be normally at 3 o'clock, because this session was moved just because of Simon. I wanted Simon to go, Monday working in the normal condition, not talking all the night, and suddenly today in the morning, Simon decided that his lecture will be at night, because he misunderstood time. 12 o'clock, that he was thinking that at midnight, so he was really stressed. But so this is why we moved this session early. So see you again, and we would like also to get if you want some comments regarding how it's going. I'm not talking about yesterday, because yesterday I know that it went wrong, and we will improve. We improved actually, as you can see here. But some comments regarding the content, because I just still think I have two different ways to do presentations on next Saturday. I still undecided which way. It will be very good quality of videos that I show, but I still undecided how to do this. Okay, so thank you very much, and please write your comments. You can write in emails, and thank you. Bye.